If someone comes to me and says, I want to be healthy, I talk about the diet. Are you getting activity and are you getting outdoors?
Which aren't massive profiteering, money-making things, which is why I think they're not touted by big companies. They will always tout, take this magic supplement. It doesn't work like that.
It's really simple. Yeah. This is the thing. You see, Abs, you wanted to get into the weeds, but it's all really simple. Even yesterday, I had somebody tell me that they were diagnosed with diabetes and the doctor said it's nothing to do with diet.
I've seen professors who are in denial that diabetes is linked to diet. And it's just astonishing.
If you see a headline and it's very anti what we're doing, flip to the end and look at the conflict of interest, get down to some very basics like who was involved, how many people took part, how did they say they were meat eaters?
Yeah, that's the key, isn't it?
Yeah.
Because I remember reading a while ago, there was a study that said low carb is bad. Was it even a low carb diet they were on?
Oh, that's very common, yes.
It's just nonsense.
Yes. This is the power of you as a person. So I'm looking at the camera. This is what you can do to change your health. Take control of it and don't accept what you're told.
Welcome to the Dr. Abs podcast. Today I have a very special guest, Coach Stephen Thomas. Stephen's got an immense history in things like phlebotomy, exercise, diabetes management, lower back specialisms, and he's an absolute expert in understanding blood tests, what to look for, what kind of red herrings there may be, and what they actually mean as well. Today we're going to go through things like lipid panels, iron, talk about different minerals, vitamins, thyroid issues, all these sorts of things, even hormones. So stay tuned and check this out. Stephen, thank you very much for joining me today. It's been a long time coming. I wanted to chat to you about this for a long time. I don't think many people actually talk about the blood aspect of carnivore and looking at different markers and how they can affect different conditions and things like that. I want to start off by asking you to just sort of give us a little intro about yourself, because you've got quite a varied background. You've done a lot of different things. Tell us about what kind of things you've done in your career and also how you got into the carnivore space as well, if you wouldn't mind.
Yeah, that's fine. Thank you for inviting me. That's the first thing to say. And I love the mug. It's classy.
Headline sponsorship.
It's classy. My story starts, and sorry to go back to prehistory, but in my teenage years and also sort of in my 20s, I was very athletic and I really believed all the food guidelines, totally fell for them, hook, line and sinker. I was a pretty reasonable soccer player and also won a singles title in tennis, and at 22 I did a bodybuilding show, so quite a sort of broad range of sports. But the reason for that is to set people up into why did I get so unhealthy by the time I was 40, even though I was actually pretty sporty and doing everything the food guidelines told me to do. And therein lies the story. I don't smoke, don't drink, and I did do everything the food guidelines told me to do. And by the time I was 40, everything was going south. So I didn't really do lots of Coca-Cola, or I didn't do pizza and crisps and all this sort of stuff, chocolates, sweets, Haribos, whatever. None of that. I did the things I was supposed to do. And I was pretty healthy. So whenever, I'm now 60, whenever I have comments online of, well, wow, I'm eating porridge, I'm eating oatmeal, I'm eating fruit and I'm doing all right. Yep, well, I was there. But these things catch up on you, and that was a thing I noticed. So I was always interested in sport and also interested in rehabilitation, because at 23 I was told I would be in a wheelchair by the time I was 50. At this point I'd lost both my parents and a girlfriend to cancer, and we were talking in the car before the recording about the hands that you're dealt, the cards that you're dealt. So that was the cards I was dealt. I was going to be in a wheelchair by the time I was 50. I also was told that I'd gone deaf, and I looked pretty good. I had a six-pack, looked amazing, just done the bodybuilding show, and yet here I was being told I was an old croak and that's it. My life was destined to be unfit and on medications for the rest of my life. Obviously, here I am at 60. I'm not in a wheelchair. I'm still playing football. So that didn't happen, but my brain was a little bit ignited to the fact that I was told these things categorically, shown really convincing images, and I was in a lot of pain.
And this is the medical team that told you this?
Oh, yeah, doctors, radiologists, everybody was just saying, look at these your hip is really bad, this is going to happen to you.
And what were the diagnoses?
I had lumbar Well, basically, it was L1, L2, L3 were completely gone, apparently.
Top of the lumbar.
Yeah, I was stretchered off a squash court, could not move. I was on laughing gas in the ambulance, which is quite a strange experience to know you're in pain, know you're in an ambulance, and be going. So, yeah, but I understood the reason for it, even at that point, before I was really interested in it. But it didn't feel right. It didn't feel correct. And I had a spinal tap. I was lying in bed. My head was very hot. And I've never mentioned any of this publicly, by the way. And I decided this isn't what's going to happen to me. I'm going to check myself out. And I think it's the best thing, looking back, I ever did. And I went to look for what you would call alternative therapy. I went to see an osteopath. And that was the beginning of a journey of being very interested in the difference between what you're told by very convincing people who had no nefarious reasons to do this. I mean, they totally believed what they were saying, and what the reality is. So anyway, I started to go down that route, and I kept being very fit. I got interested in sport, so I trained to be a personal trainer. I did some coaching to do that, and I really got involved in that. Did reasonably well, considering I still believed in high carb, fruit, veg, low fat, no red meat, all that sort of stuff. And then into my 30s, I wanted to do more. There was other career choices, by the way. I did stunts in films and TV.
No way.
Yeah.
Any films or TV shows we would have known?
Yeah, I was in the Ultimate Force with Ross Kemp. I was the a policeman that was pulled out of a burning car. I was the body double in a couple of the Bourne Ultimatums.
No way.
I was a stand-in for Gary Oldman on The Dark Knight.
Oh, what a phenomenal actor Gary Oldman is.
Yeah, anyway.
We digress.
Well, I did stand-up. I was on national TV a few times. The positive side of being deaf. Yeah. The funny side, you sit in the waiting room and they call out your name when it's your appointment.
For a deaf appointment.
So I did various things, but in the background, I was always really interested in health. I mean, I like the comedy and I like the media, and that was very interesting. But so I got involved in the more sort of health-giving side and rehabilitation, and then I became an advanced personal trainer.
Okay.
And one of my clients was trying to get to the Olympics, and they were type 1 diabetic. And you might have picked up a theme over this interview that I don't like to sort of know. Yeah. I like to want all the nitty-gritty, all the information. I really want to learn. So I ended up being a specialist practitioner in obesity and diabetes. But it was purely to get this person off the street, and she ended up in the Olympics. Actually, the Olympics as a javelin thrower, type 1 diabetic. It was a really big learning curve because I was also having people that couldn't even get out of a chair.
Wow.
So I had people getting out of Zimmer frames and moving for the first time in a long period of time. So
it was kind of your personal health issues that made you go deeper into the cause of those.
Oh, yeah.
And now you're obviously using that to help other people.
Yeah, 100%. Yeah. And also the fact of giving people the knowledge to make their own decisions. Yeah. Whether medication is the right thing, surgery is the right thing, or maybe trying some other way first. Because, surgery, which was being offered to me should have been the last resort. Like I say, totally no malice was intended. I'm not being derogatory to anybody. But to me now, especially, as I've encountered people with lots of surgeries, there tends to be a lot of after effects. So again, we spoke before this about the fact I also then added modules on lower back specialism being one of those things, which was really interested. I did an advanced osteopathic spinal manipulation module as well, which was really interesting. Medical acupuncture, which is incredible to learn about. There are people in Asia who undergo operations and they don't have drugs to knock them out. They use acupuncture.
Wow.
That's actually a known thing. So anyway, I don't want to dwell on that because people might think that's a bit woo-woo, but these are the realities. That
how did you get into phlebotomy? Right. I know you've got a massive history in bloods.
Yeah, well, this is the big turning point was once I started to meet real diabetics in practice rather than in the classroom, I was finding that my success rate was really poor. Maybe 20 people out of 100 were doing really well. And when I would always ask for feedback, why are you doing so well? So we'd see them every month. And they would say, well, we're ignoring what you're doing, what you're saying. We're not doing that. We're doing low carb, keto, those sort of things, which didn't have those terminologies at that point. Here's my bloods. Here is my HbA1c. Here is what I'm doing. I'm getting my bloods, but it doesn't seem to make as much sense as I was hoping. And being me, I thought, well, the best way to learn about this is to train to be a phlebotomist. I ended up being able to go into the NHS and do phlebotomy anywhere, and I really got into it and wrote a book about it, as you know, recently. And speaking to the doctors that were doing the reviews, there was a lot of, this doesn't seem to relate to what the person in front of me is. So,
could you explain that?
Yeah, absolutely. They would say this person has iron overload, for instance. There's a big problem, or they're anemic. That might be an easier one. I said, but they don't present with anemia. They're not pale. They don't have bleeding gums. They don't have any pains. They're not fatigued.
Yeah.
And it made no sense. And it made no sense in the context of the normative ranges. So we're going straight into this, I guess.
Yeah.
The normative ranges are, maybe 70 years old. So a lot of the tests we do are very old technology, and they have no nuance whatsoever. So these people that were doing low carb, for instance, and we were looking at their ranges, made no sense, because it would say you're diabetic, but they clearly weren't. And when they were lucky enough to have the money to do their own bloods at home, and only this morning I had a comment from someone saying my HbA1c allegedly is 5.8, but my home readings, sticking my fingers and doing my own blood glucose 3 times a day, my average is actually 4.7.
Okay.
So there's huge discrepancy. So
can I play devil's advocate for that? I want to push you.
Yeah, of course you can.
Why is there that difference? Sure, someone would normally think a hospital's got more expensive equipment, better equipment. Why are they getting a different reading at home to a hospital?
Because they're basing it on a calculation, which makes an assumption. So, abs, you've gone straight for the jugular, which is fine.
Yeah.
The HbA1c is the classic calculation that starts off on a basic premise which is incorrect. So how you work it out is you obviously take the blood sample, and then you do your measurements, but you also have to then add a calculation, which is assuming that red blood cells last 120 days. Now,
that's the key, isn't it?
That's the key. When I did my phlebotomy, one of the things I was told was, if you have a full panel, you must ignore an artificially low HbA1c because you have other things that show that this person is, say, for instance, hemolytic anemic. That means their red blood cells die too soon. So the HbA1c has to be thrown out. It's going to give that person a false sense of where they are.
Okay.
And it doesn't take a rocket scientist to think, well, if you can have an artificially low reading because your red blood cells die too soon, could you have an artificially high one if they live longer? And that's what happens.
Premise, yeah.
That is exactly what happens. So
what would you say is the normal in terms of the lifestyle? What's taught?
Well, what is taught, or more to the point, what labs use, is normally about 120 days. Okay, so if your red blood cells live 150 days, we can't say exactly because the reticulocyte count does not tell you the actual age, but there are some other markers and other things we'll talk about which sort of prove this even more. But you can do a reticulocyte count, which looks at the release of red blood cells or the immature red blood cells from the bone marrow. And if the percentage is very low, then it's showing you there's not a high turnover. Therefore, you've got red blood cells that are living longer. But more interestingly is practical clinical experience of people constantly. So you were a CGM, you would be able to tell me from your CGM, which is a constant measurement, which reacts to everything you're eating over a 24-hour period, 7 days a week. This is what your average blood glucose is.
Yeah.
You can also use other devices to back up that data. You can use a finger prick, and which is possibly even better.
I think so.
Yeah. Because you're going direct to the blood, not the interstitial fluid. But you can then say to yourself, right, well, I know categorically over the last 30 days, taking 3 readings a day, morning, evening, midday, whatever, my average is pretty good. And yet when I go to get my labs, my HbA1c is artificially high. You don't say that, you just say, look, it's high. Now, this constantly comes up in the low-carb space a bit, keto more, and carnivore, wow.
What do you, when you're looking at that in a traditional sort of allopathic context, if you're in a phlebotomy lab, do they assign a number as high? And if you're above that, you class as high?
Yeah, well, basically, you have the ranges, like above 5.7, you are, pre-diabetic, and then over 6, depends on the lab. Sure. That will say you're diabetic. So going back to the analogy of me being told I'm going to be in a wheelchair by the time I'm 50, a carnivore could be told after a year of successfully being a carnivore and seeing their blood pressure come down, their body composition improve, brain fog go in, sleeping better. Yeah, this is all well and good, but your HbA1c is telling me you're becoming diabetic. Now, that panel should also have fasted glucose, fasted insulin, C-peptide, which is a fantastic proxy marker for production of insulin. Because
we're going to talk about that today,
So you can really see your markers, what insulin you're producing, what your actual blood glucose is, what your insulin actually is. And then you have this anomaly, this HbA1c. So it is a flawed metric. I mean, it really is that simple. Your red blood cells are lasting longer. Now, I think Professor Ben Bickman, Paul Mason have talked about this as well. I'm not the lone wolf. I have been talking about it for over 5 years. And that's based on actual people.
Yeah.
So that was the thing that really sort of lit my fire, so to speak, was before carnivore, before keto, before low carb, actual real people coming in and me scratching my head and saying, well, this 20% of people are doing so well and they're ignoring everything. Yeah. But they were also ignoring the HbA1c, especially those that were rich enough to be able to do their own blood testing, because they were seeing it. Yeah. And it's only really, maybe in the last decade, I did the bloods for about a decade, the last decade when I've realised that the normative ranges are stopping virtually everything, the proper diagnosis of everything, because it's all based on these flawed assumptions. Many of them are 70 years old. The tests aren't accurate. They're not even testing the actual thing you think. Yeah. So the ones that are always anomalous, the eGFR, literally is an estimate. Yeah. The HbA1c is a calculation. LDL is a calculation.
Yeah, exactly.
So we've got to get into actual measurements of the thing you're looking at. Yeah.
Could you, I appreciate some viewers maybe don't know what HbA1c is. Actually, probably should have started that. Would you be able to explain in layman's terms what a HbA1c is?
Well, your red blood cells can be glycated, which is basically sugar sticks to them. Yeah. And over a period of time, more sugar will stick to them. And that's glycation in a real basic layman's way. Yeah. And therefore, if your reading is 4, then there's not much sugar sticking to your red blood cells. If it's 7, then there's a lot. Yeah. Now, if it's always over 120 days, that's a perfect thing. That's an absolute perfect measurement, isn't it? Yeah. Because, if it's 4 over 120 days, that's pretty low. And if it's 7 over 120 days, it's high.
And is the 4 or 7, is that a percentage? Is it millimoles per litre? Is it something else?
Well, the thing is, I was very aware of the fact you might have Americans watching. Yeah. So I bought some sort of conversion charts.
Oh, amazing.
So
this is the most prepared guest I've ever had here. Fantastic.
Yeah, I mean, when you're looking at bloods, for instance, let's nail all of this. So, for instance, on the American sites, they always say it's got to be 100 milligrams per deciliter. So that's a quantifiable measurement. That's 5.6 millimoles per litre. I don't really want to get too much into it. Yeah. But both of those, they're arbitrary. Yeah. But they're also saying try and be below 100 based on previous knowledge. See, I'm not overly worried if someone is at, say, 110. So the range here I've got here is from 70 to 300. And you can see people at 280 milligrams per deciliter or 15.5. Well, that's just showing you the concentration of sugar in your blood.
Yeah.
I want to go back to being more basic, actually, if that's okay.
Of course, please, yeah.
Your blood, you have about 5 litres of blood, and your body wants to have roughly a teaspoon of sugar in that blood.
Yeah.
And we operate pretty well at that level. And anything above that is deemed to be toxic, and anything below that is deemed to be hypoglycemic, not enough. But some people will survive and be thriving, actually, on less than a teaspoon, but maybe by only 10%.
Yeah.
Because these numbers actually sort of exaggerate the differences. There's not much difference between being diabetic and non-diabetic if you look at the volume of sugar that's actually in your bloodstream. So with that in mind, for instance, if you had a Coca-Cola like this, let's plug the studio here, that would have 9 teaspoons of sugar in.
Yeah.
Well, 9 teaspoons of sugar is 8 teaspoons too many. So the body will really rush to get that blood sugar, concentration of sugar out.
Yeah.
So this explains things like if you go to the doctor and you say, well, I've been drinking ever such a lot of water.
Yeah.
Well, that's your body being really smart. It's just basically trying to dilute the sugar.
Yeah.
And also I'm going to the toilet a lot. I'm urinating ever such a lot. Well, that's your body excreting the sugar. So these are the mechanisms that first happen to alert you to the fact that you might be diabetic. And you can do something about it. And this is where it gets very frustrating, because blood glucose is the result of eating lots of carbohydrates. And yet the advice is to carry on with those carbohydrates.
It's absurd, right?
Which is absolutely absurd. Because to me, if you take it to what I was saying about teaspoons of sugar, and you woke up in the morning and you had to administer 1 teaspoon of sugar to get through the day, that's fine, right, okay.
Yeah.
Then if someone came in and said, oh, by the way, it's midday, I'm going to give you 9 teaspoons, you'd be, is this good? Because I know for a fact I only need a teaspoon. Oh, yeah, standard advice. It's advice we give to everybody. We can spread it over 3 meals if you like. Now, I'm now reverting back to my training, because when my training was happening and they said you dose the insulin in relation to your carbohydrate intake, I did put my hand up and go, why don't you just reduce your carbohydrate intake?
Yeah, exactly. That's
really,
exactly
really
what I
simple.
think.
It's so simple. And that's why I try to use more basic analogies.
Yeah.
Because it is ludicrous.
Yeah.
It really is ludicrous. The other thing is, going off track, but we'll come back.
Yeah,
it's
sure.
not a problem. When people say, well, it's fat or proteins that are causing diabetes, well, not in my experience, because when people take the carbohydrates out, if they're type 2 diabetic, it reverses their type 2 diabetes. I have, as you mentioned, over 1,000 clients. At least 200 of those have got off their diabetic meds by removing carbohydrates.
Yeah.
If carbohydrates weren't the cause, that would not happen.
Yeah.
And we're not talking a special cohort of people that are lean and athletic or whatever, or particularly obese.
Yeah.
This is a broad range of people, both sexes, many different continents,
different ages,
everything.
Yeah.
It's completely randomised if you look at a population, and it works. It totally works. It's long term. Then we're going to dial back to the bloods. Even though they've got a relationship with me and they've seen this, as soon as they get their labs back from their doctor and they've been flagged up because their HbA1c is going through the roof, they don't understand. And you have to explain it, like I've just tried to explain it here, that it is a measurement which is flawed. It's not taking into consideration the other metrics. Now, I'm going to put a little caveat in. If your fasted blood glucose is up and your fasted insulin is up and your C-peptide is up and your HbA1c is up, you possibly have an issue. And I've seen that never. I've never seen that. It's always been the measurement factor that has been the problem.
Right. And could you give us an idea of what kind of conditions, medical conditions, do cause things in terms of HbA1c to go up and down? Obviously, you mentioned diabetes, if it's on the top end, anemia if it's on the bottom end. Anything else that you think would lead to things going up or down?
Well, not really. I mean, what will push that up is it's still, if you overeat carbohydrates, it will go up.
Yeah.
But I'm trying to look at it from the other point of view, that it's not really a reliable metric if you're low carb or carnivore, because
Agreed.
you don't eat loads of carbohydrates, and even if you did occasionally. It's not going to push it up that high.
And the carnivore clients that you have, when you say the HbA1c goes up on carnivore, I think people start to understand why now, and it's not a problem. When you say high, what on carnivore, what kind of numbers are you seeing?
That's a great question, because it's not high. I've never seen over 6 in the UK, which is 110.
Okay.
That's a really good question. Probably 5.8. It's to the point where they've been much lower, and then they've watched influencers who say, you should be, I'd like to see this reading, etc., etc., not understanding the HbA1c is flawed.
Yeah.
I can get into a little bit about the actual bloods being under 100. I don't think that is that important. It's more important to not have spikes.
Yeah.
If you're eating, for instance, 3 times a day and you're having a spike and it takes it up to 150 and then it drops to 50 and then it goes back up to 150 next time you eat, down to 50, 150, your average is 100. I would not be happy if I was seeing these troughs and spikes, whereas if someone came in and said, mine's 110, but it's flat across the board, I would be much happier with that.
It's a question of statistics, isn't it, at the end of the day, because you have that same issue in studies.
Yes.
And statistics can be so misleading because of the way you personally interpret them.
Yes.
And I think we would both agree that the issue with bloods is, and you mentioned normative ranges, what is normal?
Exactly. Yeah.
And, that is someone's opinion. It was an opinion formed in some cases 70 years ago, like you say, where we have completely different diet now to back then. And I think a lot of people, tell me if you agree, but I think a lot of people confuse the term normal with common. Just because something is common, it doesn't mean it's normal, right?
Yeah, absolutely. And not optimal as well. Yeah. That's the thing. I did a thought experiment with one of my clients, which I'll bring to the table now. I haven't got the actual figures here, but they're so easy to remember. Because for 4 years, he's been doggedly chased by his practitioner or his physician, because he has what the medical profession deem as subclinical TSH, which is thyroid stimulating hormone. And he sent me 4 years of labs. And we looked at that, and we looked at his T4, which is the thyroid 4 iodines. That's all that means. So firstly, he feels great. And he said, I've been carnivore a long time, and I feel fantastic. But they're just on my case all the time.
Is this his GP, basically?
Yeah, basically, yeah. The TSH is always really subclinical, is the phrase they use. So I can give you these details. He's quite happy to provide the details. I did check with him. But anyway, we looked from 2020 at his levels of TSH. Now, the normal range, normative values, the thing we just spoke about, was 0.4 to 4.
Which is a huge
range in the first. Yeah, absolutely. We could get
literally an order of magnitude higher.
Yes, yeah, absolutely. So not particularly nuanced. So I'm glad you mentioned that, because that's another bugbear of mine. Anyway, we looked at his TSH, thyroid stimulating hormone, and it was 0.3, 0.37, 0.31 over the 4 years. Always these sort of ranges. I said, right, what does TSH really essentially do? Do you know that? And he said, yeah, I do. It helps me produce my T4, my storage form of thyroid hormone. I went, I've taught you well. This is great. So let's have a look at the range there, which was 10 to 20. And every single time he had his labs done, his T4 was pretty much slap back in the middle, pretty much 15, 14, 16, as we talked about that. Yeah. But the average is pretty much in the middle. And I said, look, let's imagine you're the first person on earth that's ever had these bloods taken. And I am the person that's going to set the ranges. I would look at the function of TSH as primarily giving me T4 coming out of my thyroid. And yours is in this range that's making you really healthy. And also, let's look at the medical profession. They're saying this is a great range. So I'm going to have to conclude that your TSH is perfect because it does the job. Yeah. And in fact, if it was in range, if it was not 0.4, let's say it was 4, you would have way too much T4. So you'd be hypothyroid, wouldn't you? You'd be producing too much. So in that one experiment, he was like, oh, I'm never worried again.
It's almost like an efficiency, right? You need less TSH to get the same result.
Yes.
It's like a car needing less fuel to go the same distance.
Absolutely.
Doesn't mean it's a problem.
No.
It means the engine is more efficient.
It's more efficient. In fact, this is a common theme I am now finding, that when we start to look at bloods in a completely different way, this is speculation, by the way, but I will be able to come to the table in about 6 months with a few more case studies. But the reverse,
I'd love to get you back at that point.
Reverse T3 seems to be a function of moderating T3.
Right.
So many people say on keto, it's tanked my T3. It's tanked it.
Actually, I'll tell you what, before we get into this, could you just say to the viewers what TSH, T1, T2, T3, and T4 are? I know some people will just have no idea what the hell you're talking about right now.
Well, it is more basic than it seems. Everything is. So T stands for thyroid or thyroid hormone, and the numbers relate to how many iodine molecules are on that particle, basically, or on that molecule. So if you I've got T4, that's a storage form of thyroid hormone. It's not active, so it needs something to take one of the iodines off. And I would like to have a graphic here, but the way it's laid out, when you look at it, it takes a particular iodine off a particular place, and that makes it active.
Yeah.
Reverse T3, so let's pretend taking it off here was perfect. Taking it off here gives you reverse T3, because if you're looking at it as a reverse image, but it also makes the metabolic functions of that hormone now work slightly differently.
So to go from, so you've got T4 with 4 iodines on.
Yeah.
You take one off.
You got
in
T3.
A particular side, you've got T3.
Yeah.
And you take it on the other side, so it's kind of still symmetrical, and that makes it T2.
No. If you take another one off, it's T2. But if you only take the one off, it's reverse
T3.
Reverse T3.
Yeah.
And they're the ones of interest, and they're the ones that are always in the panel.
4 and 3.
Yeah, 4 and 3 versus T. Well, see, this is it. How far do you want to go?
That's what I was getting at. Yeah.
Okay. Right. If you want to know as much about the thyroid as possible, then you also need to look at cofactors and antibodies, and people that really know about thyroid will be saying there's more to it than that, and there is. So the first thing I need to say is getting tests beyond TSH are very difficult within the NHS in the UK, and I can't speak about elsewhere, because it's very reductive the way they think, that if TSH is in range, pretty much everything's fine. That's their opinion. That isn't the case. And with bloods, a common theme I get is my bloods are perfect, but I feel awful. And I get that in coaching.
I've seen that, yeah.
Yeah, we'll send bloods.
Tells you what you need to know about what these normative ranges are.
Yes, it does actually tell you everything. So if you wanted to know more about thyroid, I'm going to jump the queue and talk about clinical presentation first. That trumps absolutely everything. If your numbers are perfect and you feel terrible, there is something up. If your numbers are trash and you feel brilliant, then you've got to take that into consideration.
That it's not trash, basically.
Yeah, it's not trash. Is it somebody else's opinion that you're actually alluding to? So thyroid hormone testing, you do TSH, the thyroid stimulating hormone. There is a hormone before that from the pituitary gland, which you could get tested, but I'm not going to get into that because I'm talking about what most people can get. So the TSH is a really good start. So that's the thing that stimulates the thyroid. It's not a thyroid hormone. It is coming from above to the thyroid to say, right, you need to do something. So that's why it's called stimulating hormone. And then that will become T4, which is thyroid before iodines. It does make a little bit of T3, but let's keep this nice and simple. So that's the storage form, which goes off into your body, gets stored, and then the peripheral tissue will activate T3. And that's like the gas pedal. You put your gas pedal on. That's your metabolic rate and your temperature regulation. So that is worth testing. You want to get the reverse T3 as well, if you can. Free T3 and free T4 are the thyroid hormones that are not bound to anything. They're quite handy to have, but not essential. And then you've got the TPO and TG antibodies, which are the things that are looking at what is your body attacking the thyroid. It's not really attacking the thyroid, it's sort of attacking within the functional unit where there's colloid and where you've got iodide, where that's been right, I've got jumped. But anyway, basically the two antibodies that you need to look at, TPO and TG, and they are cofactors in the manufacture of thyroid hormone. This is where other things come into play, which is why selenium, for instance, will be part of that manufacture of thyroid hormone. So I would also test for not just the antibodies, but also selenium. So we look at that cofactor. I think you could look at zinc. Zinc is pretty much a good thing to look at when you're looking at metabolic health, because it's involved in so much transfer of energy in and out of cells, and I think I would definitely add that as well. CRP is always good if you're worried about it's not the thyroid, it's maybe an inflammatory thing that's having a knock-on effect. So CRP is a C-reactive protein. It's a protein that reacts, hence its name, in relation to inflammation in the body. There you've got a pretty good thyroid panel.
Yeah.
So that would give you some good ideas. Then it's, when did you have the test? Did you have it first thing in the morning? Did you have it midday? Did you have it 8 hours fasted, 12 hours fasted?
And again, why does that make a difference?
Because it changes the numbers. So if you're not fasted, it will give you a completely different set. Your metabolic set point is looking at these ranges, right? So I'm not actually saying that you have to do this, but what I'm saying because everyone else has done that, all those ranges are based on fasted 8 hours to 12 hours. If you want to look at where you are in this, in this realm, then you've got to do the same thing. Otherwise, you have no frame of reference. But this is, again, something I say to people. If this is not practical, you've got to set yourself a new benchmark and then repeat that for your own tests. So if you find it difficult to fast for 12 hours or 8 hours, and I'm not recommending this, but if there is a situation where you can only fast for 6, you've got to then make sure that every time you have a reading done, that it's 6 hours. Because if one time you've fasted for 6, I know it sounds really obvious, and the next time it's fasted for 18 hours, you can't see the trend that you're looking for. So it's all about a proper experiment. If you're going to buy a hack, you might as well do it properly. So for me, just make it a broad statement of between 8 to 12 hours keeps you in sort of what everyone else does, so you can compare yourself to your friends or other people online or in the community and know exactly where you stand. But I think thyroid, if we go to the sort of classic T3 as tanking, well, that's because you're not eating glucose so much. So T3 is pyruvate dehydrogenase enzyme. There's a movement of pyruvate across the mitochondrial membrane, which T3 is involved in. That's not the way we metabolize our nutrients. We're not eating loads of glucose. So that mechanism, you need a lot less T3. Which is totally explainable because we're looking at fat oxidation and using fat rather than glucose. So when people say that, is it tanked? And again, clinical experience. Had a coaching call last week where the guy was worried. Luckily, and this is where the T3 comes in, we were looking at the whole panel. He's lucky enough to have the money to have a whole panel. And we realised that because he's very strict carnivore, his T3 has got lower and lower as he's become stricter and stricter, ex-vegan, so I don't hold that against him. And it's just, it's predictable. Because what's happened is you've got this lowering of T3 down here, and reverse T3's gone up. And it is a direct relationship. So I'm beginning to realise this is total speculation, right? So if it's wrong, I do apologise. I know this is evergreen. That there is a regulatory factor to reverse T3. It's not a random mutation, which is sort of how it's presented to a lot of people. It isn't a mistake necessarily. Now, there are people with dysregulated thyroid where it's due to the lack of other things like iodine in the diet or exposure to things that they shouldn't be exposed to, heavy metals, those sort of things. So I feel the bloods are a really good gateway into learning all about everything, because it starts to be interlinked. Because once you start looking at, well, the HbA1c is a bit flawed, and people are talking about reverse T3, or they're not even mentioning it. and then you're looking at iron, how we process iron, our potential iron overload, which is another stupid thing they talk about with carnivore.
Yeah, we'll touch on that today for sure.
Why is your ferritin gone high? Well, I sort of know that. It becomes a jigsaw puzzle that just starts to make total sense.
Yeah.
Now, some clients, and this is a new thing, I'm trying to get the clients that do the coaching session. As one client said to me, it's really great. I go to my GP, and then when I speak to you, you talk me off the ledge, right? And I thought that was a great expression because it makes sense. You see, if you go to a doctor and they say your labs are terrible, and you're sitting there and saying, well, I'm in trousers or pants for the Americans, that I haven't been able to fit into for 15 years, and I've got more energy than I've ever had, and I'm sleeping better and my brain fog's gone. You've got this set of paper, you've got these lab results that are telling you that I'm sick, and I'm sitting in front of you telling you that I'm not. Yeah. And
it just breaks your heart, doesn't it?
Yes, it's tiring.
I've been through the degree in university. It's like we're given these blinkers, and the blinkers say what you can see is the guidelines. And if you don't follow those guidelines, you are in trouble, because you've got to justify yourself. You've got to show, why you think what you're thinking when the guidelines say this. You've got to defend yourself if in front of a regulator, etc., etc. It's just like independent thinking just isn't allowed anymore. And when you've got exactly what you say, a patient is sat there feeling fantastic, things are in remission, they're fitting in trousers they couldn't fit in before. Why are we looking at a piece of paper? Why are we prioritizing the piece of paper above the patient, at least? There's nothing wrong with having the results and having a look. But I think that should be a learning experience. It's not a corrective experience. If the clinical presentation is much better. So at the end of the day, what are we here for? To treat a piece of paper or a patient. And it's a tragedy. It's a complete tragedy.
It is.
Yeah.
It's frustrating as well, because from my experience of doing the success stories, very often there's no interest in these miraculous stories. I mean, I've now done 3 on MS, where
multiple sclerosis for those.
Yes, where there are injuries you can see on images, and all 3 of them had the result, from brain imaging, no more lesions. Yeah, and that's categoric. That they've seen progression of lesions over years or months or however long they've been tracking, and all of a sudden this person's gone to this new way of eating. And Kevin, who's pretty well known, Kevin Smith, he tells a story where the physician came in and slammed the report on the table and said, "This shouldn't happen."
Wow.
Oh, what shouldn't happen? You shouldn't have no new lesions. And it's frustrating because it's miraculous. Only yesterday that, a 24-year-old who, pretty glamorous female, looking really fit, strong and vital, and she's been carnivore, but she's been riddled with illness literally from the get-go, from birth, and she can't believe how great she feels. And, 8 surgeries and constant problems. Yes, constant. And you wouldn't believe it looking at her. And carnivore has saved her life, but one of the things that she couldn't believe is having no lesion progression on her MS. Yeah. You would not even know she's got MS.
Really?
And if you read her story and medical history, you would not expect the person on the screen that you're seeing. Wow. But this way of eating has just absolutely changed everything.
100%.
And I think a very common thing I have said to me from success stories, and these success stories are not my success stories. These are these people. They've done the research. They've made the decision to go carnivore. I didn't do that. I've not sat down in a group and gone, right, okay,
you need to do this.
An option. Yeah. Right, so I'm not taking any credit for this. Far from it, actually. This is the power of you as a person. So I'm looking at the camera. This is what you can do to change your health. Take control of it. Do some research. Learn some things about the body. And don't accept what you're told. Yeah. So even things like, ChatGPT or Google, don't accept that first answer. If you're into ChatGPT and the AI, ask a question. If it doesn't make any sense, you can interrogate it. I have literally had brilliant screenshot examples of how ludicrous it is. And one was that I was doing a talk and we were talking about stable isotope testing, and I just wanted to quick question, what is the percentage of animal flesh and fats that we've eaten in the Paleolithic period based on stable isotope testing? And ChatGPT said it's approximately 20% animal protein. Yeah, you laugh already. You know what's coming. And 80% plants. Now, a lot of people would say, "Oh, it's on the computer," and I think that must be true. And I put in, because it's conversational, I think you might have that wrong. I believe there's studies that show it's the complete reverse of that.
Yeah.
And it actually wrote, "Oops."
Really?
Yeah, oops. Yes, you're right. It was 80% animal.
Yeah, I mean, Bendor 2017 is the reference people want to look up if they're interested in that.
Yeah.
I'm interested, what made you carnivore? How, obviously you described the illnesses that you had.
Yeah.
Something must have made you obviously said, I want to do my own thing.
Yeah.
What planted that seed?
Yeah, sorry. I didn't really explain what happened in my 40s.
That's all right. No, go for
okay. So what happened in my 40s was my health, despite having lots of running. I was an advanced personal trainer. I was doing everything. No red meat, no saturated fat, skim milk, porridge oats, fresh fruit, vegetables, doing all that stuff. Honey, by the way, Mr. Saladino.
Yeah.
And I became pre-diabetic. Because I was doing my own bloods, I was able to test this myself. Pre-diabetic. Oh, that explains why I'm getting a bit tubbier. I mean, I'm not great with my weight. When I try to gain a bit of muscle, I always gain a bit of belly fat. And then when I try to cut, it goes quick as well. But I couldn't get rid of any belly fat ever at all, whatever I did. That made no sense. And because my mother died of that horrendous 9-pound cancer growth, colon cancer she had, I had lower left quadrant pain. So I went and had a colonoscopy. I can remember sitting in the outpatients waiting for the result and thinking, this is it. My cards are marked. This is the cards I've been dealt. I was also interested in biohacking at this point, and I had a coronary artery calcium scan of 639. Right, so that's pretty bad. So all this, being the poster boy for the food guidelines, not smoking, not drinking, being fully mobile, so not needing to move more, not eating lots, and certainly not eating any rubbish, my health was tanked. It was terrible. And like I say, going back to the practice, everyone that was low carb was doing really well. I will get to the carnivore, but I think we need to talk about the transition.
Give us a context.
So I got to age 50 and I just thought, right, okay. And it's a bit like a Seinfeld episode. If everything I do and follow has got me into this state, if I do the exact opposite, I'm going to get better because of, the correlation.
It's common sense, really, at the end of the day.
So it did. And all these people were telling me it worked. Oh, wow. Within the first 3 or 4 weeks of low carb, I lost a little bit of water weight, but that's still great.
Reduced inflammation, really, is one of the reasons for that, isn't it? Yeah.
But the thing is, if you've not lost weight, even if you lose water weight, you start to think, oh, this is interesting. Quite like this effect. Sleeping was better, all those sort of things. Sorry, you were going to ask?
No, just stretching my arm.
Oh, right.
This is live, if you can't tell.
And it was just amazing. Things just improved. Now, there are low-level things that people don't believe can clear up by just diet, which I find remarkable now, but I understand why people don't believe it. I had niggly things, like I'd always had athlete's foot, could not get rid of athlete's foot. I used to have a stress spot here, looked like somebody got a strawberry and smacked it against my head. Whenever I was stressed, that would come up. And so I tried low carb, and it was pretty good. And I started to ask people to try it, and people I was coaching, and they were getting better results, which is great. And so the logical step is, well, if you take a certain amount of carbohydrates out, what if you take even more and go keto? So I went keto. So I was 53 at this point, and boy, that was another leap. And I was thinking, wow, this is amazing. The more carbs I take out, the better it is. I was following, the normal ones like Dr. Ken Berry, and he was going through a sort of parallel experience where he used to push eat your greens and all this sort of stuff, and he was taking the veg out more and more and going towards what obviously subsequently was carnivore. And it just started to hit me that maybe there's this other way of eating that I haven't even tried, and definitely is a little bit crazy. At this point, I'd never heard of Sean Baker, by the way. So I was introduced to Sean Baker online, and I thought this is brilliant. And he was offering coaching to be an online coach, but one of the stipulations was you had to be carnivore. Made sense because that's what you were doing. Carnivore coaching, it's best to have your own experience of it. So I did it for 30 days on my 55th birthday. 6.5 years later, that's the best 30 days I've ever done because it's just self-evident. Part of the reason I think he wants people to do carnivore is once you've done it, you believe in it.
Yeah,
if you do it properly,
you never go back.
No, it won't go back.
Yeah,
no,
I wouldn't.
No. And I have done a few interviews with influencers that are adding back fruit and honey just to see what happens. I have no interest in that whatsoever. Certainly when you're looking at the fructose and the damage that can do to the liver, and it's 11 times more glycated in the glucose. But anyway, this isn't about preaching, is it? It's about why you did it. So I went carnivore, and I just totally fell for it. Did 2 years at MeatRx as a coach there under the sort of wing of Sean Baker.
Could you just explain what MeatRx is for those that are new to this?
It was his website, which was meat-based, hence MeatRx. It doesn't exist now, it's now Revero. And we had a daily meeting, which Sean would host, and we would talk about the carnivore diet and success stories and all that sort of stuff. And it was community support, it was fantastic. Met some really good coaches. I met Raymond Nazon there and Emily Harvo and all this sort of, it was nice atmosphere to be in, like online Zoom meetings and getting lots of success. Sean did this daily meeting, and if he couldn't make it at the end, I was sort of standing in for Sean, which was nice as well.
I think I did on the 24-hour.
yes, so did that, and then Raymond left, by the way, and I joined the Steak and Butter gang. So Bella was a brilliant influencer to follow as well, which I think was good. So the whole carnivore space was just brilliant, and the community feel was great. It's very encouraging, and it's tasty.
Yeah, absolutely.
And so the things that have improved. I'm going to talk about the weird things first. I mean, I used to think that farting was normal. Gas was normal.
I did.
Yeah.
I just don't do it now.
Yeah, don't do that. So that's good. The athlete's foot went. There's a nice kicker to the end of this. And
was that a pun? Athlete's foot and kicker?
No. That's take two. Right. I'm going to pretend I really meant that. So athlete's foot went. The stress mark went. Lower left quadrant pain went. My body composition got better. It isn't at the moment because I'm putting on muscle, and that always brings a little bit of weight gain with it, which is a bit frustrating for me personally. That's Keto Savage's fault because he said it's easier to gain muscle when you're not worried about being lean. So I agree with him. So anyway, so that went. Sleep got better. Cognitive function got better. I nearly forgot that one. Brain fog, that went. Just everything.
Yeah.
Right? But I also have my hearing assessed.
Yeah.
I've got severe hearing loss, got hearing aids in now. I rely on a little bit of lip reading. I can't use telephones. As we've found
I accidentally rung Stephen as I was picking him up, and I felt really bad now.
And my hearing has got worse and worse and worse for many, many years, since 23. And then the deterioration started once I got low carb and keto. The deterioration of my hearing slowed down. So I was getting more deaf but less pronounced. Can't think of a better way of putting it. So my graph of deterioration was like this, and it started to level out. And then when I went carnivore, there was an uptick.
Wow. And
my audiologist would not have it. He's a good scientist because he said, it must be the equipment. This doesn't make any sense. I'm like, it makes sense to me because I think it's my diet. Tinnitus also went, or tinnitus.
No way.
Yeah.
Tinnitus.
Yeah.
Wow.
So I'm very, very much in tune with my hearing and the environment and all that sort of stuff, which is why I'm more visual. When you scratched your arm, you know, it's made me more visual. So there's a slight uptick in hearing, which is not going to come back. Yeah. But the point being that this deterioration stopped, and now it's slightly better. Yeah. So going back to the coronary artery calcium scan, I do want to do that. But for biohacking purposes, I don't want to jump the queue, because even if you pay privately, you are taking a slot, and that slot could be someone on the NHS. And we've got a huge waiting list for that. So I'm not doing that yet, but I will do that. And I will do exactly the same thing as I just said about my hearing. I will look at, firstly, 639 as a baseline. What is the normal progression? And this is where people have got to look at these numbers in a better way, rather than is it less or is it more? Let's say the assumed rate of growth is X, so you're imagining plotting out there.
Yeah.
And mine is, it's got worse. Let's say it's got worse, but it's not where it should be. It's better than we expected. It might have just halted it, or it might reverse it and lower it, which again, I've had success stories where people have categorically gone from, in the hundreds down to the teens. We've seen it. So that could happen as well. So I think that's one of the things that I find particularly interesting, again, going back to the bloods, is these tests. There's more nuance to the coronary artery calcium scan, for instance, compared to cholesterol testing, which is 70-year-old. It doesn't have to be. Cholesterol isn't directly measured. Again, that's a calculation based on other things that they can measure. So it's still an assumption. And now we've got, I say now, I mean, it's 30 years. Now we have nuclear magnetic resonance, like an MRI, but it's looking at bloods differently, and you can do the particle sizes and the fractions, the protein fractions in the blood, much, much more nuanced. And this is where you get into small, small, dense and
SD,
large
fluffy, etc.
and all that sort of stuff. I'm not saying that is the best marker for heart disease or whatever, but if you're going to do your bloods and you're looking at the things that can potentially cause you problems, even if they're causing you a problem because they're trying to save you rather than kill you, then why are we not doing that? Why are we still having these LDL or lipid panels, which are totally irrelevant anyway?
Yeah. Oh, I mean, let's talk about lipid panels. So why don't you give us a rough idea? If an average person was to get an average, in inverted commas, lipid panel, what kind of things would you see? I mean, we've got the different cholesterol markers, we've got triglycerides. Why don't you give us an idea of what's on there?
Right, okay. Well, again, I was trying to give people the idea of the difference between the American and the English. So if we look at 100 milligrams per deciliter total cholesterol in America, it's 2.6 millimoles per litre. All right, so it's 100 or 2.6 at 100. So 200 is obviously 5.2. So when we're talking about total cholesterol, that's firstly not the greatest thing to look at. LDL is the low-density lipoprotein, is the carrier of cholesterol.
I was just about to say that LDL is not cholesterol.
It's not cholesterol.
It's a package.
Yeah. I'm assuming that your viewers know all this, so I'm going to assume they don't.
So a lot of people won't. A lot of people won't.
All right. So cholesterol is a molecule that's in LDL and it's in HDL. Well, why is that? Because fat and water don't mix, basically. So if you've got this lipid molecule and it has to go through an aqueous solution, which is blood, it needs a carrier. So low-density lipoprotein is like a carrier. It's a lipoprotein, a fat and a protein shell, and inside that will be things like triglycerides. So that's like 3 fatty acids, which is and a glycerol backbone makes a triglyceride. So that's what could also be in there, or vitamins, fat-soluble vitamins. It's a carrier, essential carrier. So I'm just going to go to sort of like the headline.
Yeah.
People that have heart attacks and die, or people that die of a heart-related condition, over 50% of them have low or normal levels of LDL cholesterol, which isn't cholesterol. So it's not a great marker.
No.
It's not a great marker. It's a 70-year-old way of measuring. And there's no correlation, really, no convincing correlation between, or you can't even say something is causal from an associative study. So even if you look at populations and try to draw conclusions from it, there's too many confounders. So, anyway, so LDL. We talk about LDL. You can also measure HDL, which is high-density lipoproteins, which people call the good cholesterol, and triglycerides, as I just explained. Now, this is all about lipids in the system and how the body utilizes them and partitions them, sends them out to cells. And we make cholesterol. 80% of the cholesterol that's in your body will have been made by your body. And it's been proven if you try to lower your cholesterol via your dietary intake, it just makes more.
And they have to pay attention to that. That's not for a coincidence or a joke.
No, it's not a coincidence. That's the whole point. So why would your body do that? Well, let's assume everybody's body is trying to kill you with cholesterol. Well, that's a ridiculous thing, because every living organism is here to survive and procreate. So there's no animal, there's no living thing that deliberately wants to kill out the whole race.
Yeah.
That doesn't happen. So if we're making cholesterol and we try to lower it and make a certain amount more, that's your genes saying, right, your genetic coding expressing that that's what the body needs.
Yeah.
And to fight it is ridiculous. Try to lower it. The only reason there are drugs to lower it is because there are drugs to lower it.
Yeah.
They tried to manipulate HDL with drugs and they couldn't do it. If they could and make money from it, we'd now be sitting here saying, is raising HDL a really good thing? Using a pharmacological solution. So there's too many things like that around it to make you think this is a good thing to look at or it has utility. So if you do look at the lipid panel, which we're stuck with for now, for most people, what is the correlation? What is the best association? What can we use? And it's certainly not LDL. That's a very poor marker of outcomes. HDL to triglyceride ratio seems to be a better one. Again, I'm not saying it is be and end all.
I think it's more associative.
Yeah. Again, it's still an association. Very roughly speaking, you want higher HDL and lower triglycerides in general, if that's what we see in populations. Now, the reason we're both being very cautious about what we say is because of things like healthy user bias. Now, I'm actually quite nice about vegans because vegans are bothered about their nutrition. All right, there are some bad examples of vegans, but in the main, they are at least trying to do something about their nutrition. They're thinking about it. But nobody does that sort of decision without other decisions happening. I don't think anyone said, right, I'm going to take control of my health. I'm going to go vegan, but I'm still going to smoke and I'm still going to drink and I'm not exercising. Or I'm not getting out of it. That just doesn't happen. So a lot of these associations are more reflective of lifestyle of the person that's chosen it. So if it looks in one study, the vegans did really well compared to the Western diet or a meat-based diet, you've got to look at, firstly, well, why is that? Well, the meat-based diets sort of cohort would be people that are eating pizza because
got pepperoni on it.
Because it's got pepperoni on it.
And that was one of the...
Yeah, that's a real thing.
That was the real thing in the study, wasn't it?
Yeah.
They classed pizza as a meat-based diet.
Ice cream is deemed as dairy, so all of these studies are particularly flawed. And I would always say to people that if you see a headline and it's very anti what we're doing, flip to the end and look at the conflict of interest. That's the first thing. Who funded the study? And then secondly, try and look at the design of the study. And it isn't as complicated as you think. You can really get down to some very basics, like who was involved, how many people took part, how did they say they were meat eaters?
That's the key, isn't it?
Yeah.
Because I remember reading a while ago, there was a study that said low carb is bad, or something like that. Was it even a low carb diet they were on?
Oh, that's very common, yes.
It's just nonsense.
Yes. I've actually seen a study where they did, again, they said low carb was bad, and they had a graph showing the consumption of carbohydrates amongst all the groups and the outcomes. And I think it was something like the lowest was 200 grams of carbs per day. And this graph just had a dotted line and said, we've extrapolated from this line what a very low carb diet would do. Well,
so it's an opinion then?
Yes, it's an opinion piece. Yes, no, it's nothing else. It's pure guesswork. But anyway, going back to the lipid panel. So then people got into the nuance of, like I say, looking at particle sizes. Yeah. And we'll come back to HdL1 triglycerides being an area of interest. So now we're looking at are the LDL particles, are they oxidized and glycated? So we spoke about those things earlier.
And they can be glycated.
Yeah, so then they become smaller. So they become small and dense, or you can have this big, buoyant, fluffy, big and fluffy. Right, now, you then get a pattern. This is the way that it's put into test tube, basically, and the density of the samples will spread out, and you'll be able to see like a shadow pattern. And it's if you looked at it on a graph, you'd have pattern A and then you'd have pattern B, which would be very different.
So you can actually see the layers in the test tube when you're in the lab.
In the tube. Yeah. So it's brilliant. It's absolutely brilliant. In fact, you could take the test tube, theoretically, sort of take a picture of it, turn it on its side and draw a graph based on the density of the shadowing. So, and that's pretty much what it does. You know, you get a tube that's sort of suddenly dark and then it's a bit lighter, and then it's dark again, and you get that pattern. Which will match
of how much there is of each particle.
Yeah, exactly. It's really simple. Yeah. This is the thing. You see, Abs, you wanted to get into the weeds, but it's all really simple.
Yeah.
So anyway, so you can get this pattern A or pattern B, and pattern A tends to be pretty good. Pattern B is pretty bad. But what clever people have done is they've said, well, if you can't afford the nuclear magnetic resonance test, you could look at your HDL and triglycerides, because we've now got the data to be able to say if you're X and X, then you're probably pattern A, and if you're X and X, Y and Y, then you're probably pattern B.
Probably being the key word.
Yeah, probably. Yeah. So are they handy? Yeah, possibly, but I still feel that other things are much more important.
I completely agree with you.
Yeah, like clinical experience.
How is the patient feeling? What is the symptomology?
Yes,
that's the key.
That's the bottom line, and we've lost that. Definitely lost that. Yeah. I love biohacking. I really think it's interesting.
Yeah.
I like the numbers. I didn't get in it because I hate numbers, but the interpretation is the thing that is the problem for me, 100%. Because it's not joined up. They will look at one marker. If it's not in range, you've got a problem.
Yeah.
And also, we're going to lower that with a medication,
which just happens to make a lot of money.
Yes, which happens to make a lot of money. I think one statin drug made $8 billion.
You're kidding me?
Yeah, I think there's 80 million Americans on statins at the moment.
Wow.
And their heart disease risk, that's plummeted, isn't it?
Yeah.
No.
Apparently.
I think there's a lot of heart disease happening right now.
Yeah.
So you would think this huge amount of people taking statins, the numbers would reduce.
Yeah.
Surely, if it's a great thing for reducing the risk of heart disease. But it's not.
No.
It's going up.
In terms of the triglycerides, you mentioned obviously the ratio between those things. Could you give an example or some idea to the folks watching what kind of things might increase triglycerides? I know we can talk about things like fructose, weight loss, things like that.
Right. Well, firstly, the measurement will be completely knocked out if you've just eaten. I think it's your levels of fat will make some difference, but also, and this is much more important, is how your body is partitioning the energy. Sorry to get into a bit more technical stuff, but
that's exactly what it's for.
Let's make it more basic. Are you a sugar burner or a fat burner?
Yeah.
Right. So you could have people that you had Richard on here a couple of weeks ago. You know, Richard doesn't bother about his ketone levels, for instance, but when he does measure it for for a video or something, it's always low. Mine are always low, 0.4 or something like that. Never worry about it.
I don't care either.
Right, I don't care. I think my fat utilization is great and my glucose is in range. So I'm not overly worried. But other people might not be that fat adapted. So they might have more fats and more lipids in their bloodstream. Simple as that. It's still just for delivery. I'm not belittling the triglycerides as a reading. If it goes high and it's unexplained...
Yeah, you need to ask why.
Yeah, you need to ask why. But if you are eating this way and you see a slight bump in your triglycerides, you could look at when you're eating, your frequency, whether you're doing 1 meal a day, in which case there's a lot more transport of lipids around your body. You know, the lymphatic system comes into this quite heavily. And if you're worried about triglycerides being high when you did the bloods, you could experiment with simply using the same amount of food but over 2 meals.
Yeah.
So your lowering the transporting of it around the body and getting it into the tissues easier.
Yeah.
Many people think that the adipocytes, the fat cells, the fat cells are static. Oh, I've got this bit of fat under my arm here and it's been there forever. It's constantly in flux.
Yeah.
Irrelevant of calorie deficit, it's in flux. The whole body is always in flux, and that's been proven. And actually, even the researchers were reluctant to release that, as always, because it doesn't fit the narrative. That fat there is movement in and out constantly. It is not static. So that is just getting back to how does the body manage the fat? Does it store it? Does it utilize it quickly? There's a certain amount of sort of resistance at the mitochondrial level where once it starts, say, for instance, utilizing glucose,
it's a bit of inertia.
Inertia is a good word, actually. It likes using that.
Yeah.
So
I think what I describe it to people is like if you're pushing a car and it's got momentum and then it stops, it's hard to kind of get it going again because it's a heavy weight. So if you're mostly, you're oxidizing, I should say, to be technical, or if you're mostly using glucose as your fuel source, that's the car being pushed.
Yes.
And then when you suddenly give it lipid, it's like you got to almost stop the car now and get another one going.
Yes.
And I think that's an easy way for the layman to understand it.
Yeah, and I think the body's smart.
Yeah.
If I get people very often, at least once a week, someone will say, I've bought a Keto Mojo and I'm now obsessed with all the data and my ketones.
That's the danger, I think, with those things.
Absolutely.
The obsession that comes.
Yeah, I think that's the thing about I want to get across is the numbers are not as important as the person.
Do you let's talk about things like the Keto Mojo and CGMs.
Right.
What is your opinion of them? Let's start with that. What do you think of them?
See, it seems like I'm being hypocritical. I think they're great because it puts the power in your hands, the knowledge into your hands. Nothing beats you saying, well, I don't believe that about cereal. I don't believe that about oatmeal. I'm going to eat it and see what happens.
Yeah.
And then
brilliant for that, isn't it?
Yeah, and 2 hours later, you're like, oh, wow, I didn't realise that happened. So everything you're being told, you can verify, you can check. Now, if you love watermelon, and we'll come on to sort of hopefully onto the foods that you shouldn't eat and a protocol that I'm doing at the moment for people with kidney problems. If you think that watermelon is great for you, and you do your Keto Mojo, well, it's going to tell you that your blood glucose is shot through the roof.
You've got it ass backwards.
Yeah. So it's amazing, really. So yes, it's good. The continual glucose monitor is really good, but it's understanding the data and getting away from, look at that, 0.4 ketones. What am I doing wrong?
Yeah.
Well, I had this yesterday. A really good athlete. The email I got was just, this is the best thing ever. This, literally everything's great. The best she's felt, best sleep, best performance in the gym. Just can't believe it. Wonderful. And then I got a second email saying, oh, by the way, my ketones was 0.4. Should I be worried? And I'm like,
no, it's
yeah. And I've name checked her because that's a real story, and I know she'll watch this because it's you look at what you just emailed.
Yeah.
Should you be worried?
And that's the first email is the important one.
Yes, yeah, absolutely. So I don't want other people, obviously she's really interested and open, and I love people interested in the numbers. I'd much rather that than not being interested.
It's a fine line, isn't it?
Yes.
Like being interested to learn about yourself, maybe to understand nutrition, which is noble, etc. But then being so interested, you kind of lose track of why you went in and you just think about numbers now.
Yes.
And it's a fine line that is different for every person. That I, even in my own patients, I try and educate them that there is a line to start with, to see if they can spot themselves falling for it. For me personally, CGMs I think can be great, and they can become an obsession in an unhealthy way. In my personal patients, some of the uses I like them for. Number one is for safety. Mm-hmm. So, for instance, if we are using fasting as a tool to help them lose weight, because I can't stand the use of things like Ozempic, for example, and they've never done it before, I want them to have some kind of safety marker where they look at it and say, no, I have to eat now. Yes, I want to fast, but my body's not doing well and I need to eat. So as a safety mechanism, I think it helps. I think, for a slap in the face, like you said, where they think they're doing really well, but it shows that they're absolutely not. And yet for things like that, and for motivation to see trends over time, I think they can be great. But we would both agree they can become obsessive, and people forget clinical presentation is most important.
Yeah, and I think that's true for any influencers as well, because they get wedded to these. It should be this, it should be that. I'd like to see that. I'd like to see this. Ferritin is one, and the eGFR is another one.
Yeah,
where you've got a baseline number. If we don't mind going on to the
please, let's talk about ferritin, which is an iron panel, shall we say?
We'll talk that as well. But let's do the kidney first.
Go for it, yeah. Kidney
because we were talking about calculated numbers being misleading. When I first started, I didn't realise how bad this was, but the eGFR on Carnivore can be incredibly misleading. And
could you explain what it is for people that don't know? Yeah.
So it's an estimated, that's the E, glomerular filtration rate, so the ball of yarn in your kidneys, which filters out all the stuff. I've got my protocol here, and I give these very notes to people. So it's basically filtrating your blood, and it's getting rid of the waste and keeping the good stuff, this is it. So even if there's good stuff in it, but there's too much, the idea is it will get rid of the excess. So iodine is a great example. You can do what's called an iodine clearance test. If you're not sure about your thyroid state, you can do an iodine clearance test. So you're given a drink like this, and it's got 100 units, let's say, of iodine in it, and you drink it, and over 24 hours, your urine is donated. So you give a urine sample over that period of time, and if in the urine samples there's 100 units of iodine, you're not deficient, right? So that's the iodine clearance test. So why is that relevant? Well, the kidney would be the thing that's doing that. It would be the thing that's saying, iodine, what's all this incoming iodine? We don't need it. It's too much. We'll excrete it out. So that's what the kidney does. So I was really quite worried that the eGFR would go down. So I looked into why this happens, and that's because it's the good old-fashioned calculation problem. And believe it or not, the only people that seem to know that are nursing websites. They will totally understand it. So if your eGFR, so your estimated filtration rate of your kidney, goes down, what could be the cause? Now, kidney damage is obviously one of the things that people will say straight away.
Yeah.
But if you go on the nursing website, they'll say, well, it could be because your protein intake has gone up. Could be dehydration, that's another one, another simple one as well. So always get a retest. And that's because the eGFR is based on creatinine and urea, and both of those are go up when you eat more protein because they are dealing with the waste products of protein metabolism. So I always suggest you get a cystatin C test, which is a much more direct measurement of filtration. Now people go, well, what's the difference? Well, you could be end stage, and I've had this, end stage, stage 5 kidney disease on a transplant list because of your eGFR, and when you get a cystatin C test, you're taken off the list and you move up to a stage 3 or stage 2, and that happens. That actually happens a lot. Wow. So I've had people at 14 on a transplant list.
14 years old?
No, 14. The rating is 14.
Oh, okay,
so I have had young people, but anyway. So it's your filtration rate needs to be over 60.
Yeah.
I hate using the ranges, but that's what everyone does. Has to be over 60. If it's under 15, then you're eligible to be put on the transplant list, or there's a serious problem. So anyway, I had someone at 14 reading, and the cystatin C put them at 29. So immediately they're in a different stage. There's still some things to do, still some work, but immediately
it's not as bad as they thought.
Yeah, nowhere near as bad.
And could you explain what a cystatin C is?
Well, it's a protein test. It's based more on actually what's happening at the filtration of the kidney.
Fine.
Right. So it's just more accurate, and that can make a big difference because it can be really quite pronounced. I mean, I've literally had people that have been up for dialysis get the cystatin C test, and it's over 60.
Wow.
Right. So it's hugely different. And there's a lot of variation in people's, food intake, their electrolytes. So I do this protocol with people. So I've got someone on peritoneal dialysis at the moment. And all that is they're at home at night when they're sleeping, they're hooked up to a dialysis machine, and it utilizes, your torso, the peritoneal of your body here. It uses the human filtration. It's great, okay? So I said to him, right, we're going to talk about the foods. So I'm giving away my whole spiel here. And I always give out this, and I say, so we're going to look at foods that have got phosphorus, potassium, sodium, nitrogen, and water. We're going to look at all the intakes of those things. So like water, you can eat as much as you like, drink as much as you like. I'm like, no, because we're talking about the filtration of your kidney. You need the appropriate amount of water. And if you drink gallons and gallons of water, you are giving your kidneys a lot of work to do, and you're putting your blood pressure up.
Yeah, I've got patients who say, I drink 2 litres every day, I drink 3 litres. People will say, there's massive bottles, and it's got timestamps on the side of the bottle.
I know.
What are you doing? It's
scary.
just ridiculous.
Yes.
But sorry, I didn't mean to interrupt you there.
And that's why I did it in this order, because if you say water first, you lose people.
Yeah.
So I just say we need to manage the following. Not remove, as they're all essential. That's clearly in here. So we'd look at phosphorus, potassium, sodium, nitrogen, which is the waste from protein metabolism, and water. That's what we're looking at. All right. So Coca-Cola has loads and loads of sugar, and has loads of phosphorus. Now, I then talk about sugar as an additional thing, because many kidneys are failing due to diabetes, or complication of diabetes, or overconsumption of carbohydrates. So we want to keep that really low. All right, so that's what we do. Now, I'm doing this for a reason, and I want to do this because
Please, I'd love to
the
hear
most
it.
common thing that happens when I have a kidney patient is I have 2 people on the screen, and it's the person and their wife, partner, husband, brother. There's always someone else who's interested. Now, I put this down to 2 things. One is, if you're on dialysis, you need the help of other people, and secondly, there seems to be more interest in it because it's really a quantifiable improvement you can see when things start to improve. And I think they need that sort of skepticism from outside to say, no, he's right, he is improving. Right, so we do this protocol. So I go through what's good and I explain why. So we go like whole chicken and fish and beef and egg whites, olive oil. I also include things like non-carnivore, because I have people coming to me just to talk about kidney health, and so I include other things: cabbage, onions, berries, garlic, and cucumber. Right, but this is the bit that always makes me laugh, because I then go into what's not so good, and one story in particular springs to mind. So I say what's not so good: asparagus, kale, red grapes, apples, cranberries, eggplant, buckwheat, watermelon, cauliflower, cherries, pineapple, and green beans. This is going to trigger people because there's some of the things that are supposed to be good for you, right?
Yeah.
Now, these are all people that have got kidney problems, and I would say 90%, that list of bad things gets a huge laugh. And I say, why does that get a huge laugh? And they say, because that's what he's eaten. That's what she's eaten, most of that. That's their diet.
Yeah.
I'm like, right. Well, I didn't know that, but that's got you there.
Yeah.
And that's why taking these out improves it. So going back, making it analogous to diabetes, if you've got type 2 diabetes, you take the carbohydrates out and you get off your meds, it's pretty much the carbohydrates.
Yeah, exactly.
Yeah. So I genuinely I haven't got enough yet to say here's case studies, but I have enough to do success stories, 5 success stories, and I've got more in the pipeline. When people look at this, the first thing they say, especially if they're doing peritoneal dialysis, is, oh, man, I could sleep now.
Really?
Yeah.
Just by cutting those things out?
Just cutting those things out. It's straight away. Oh, the fluid management's so much better. Because if you've got that disease, you know that disease inside out. Yeah. They are the expert in it.
So they know exactly what they should and shouldn't feel.
Yeah. And they know what's happening.
Yeah.
So he said, so I'm going to name check Tim here because he's great. I can't believe it. I want to do a success story. He's like a week and a half in.
Wow.
And he can't believe it. Sleep. And this is key, I think. I know I mentioned sleep quite a few times, being a great improvement. It's so important for repairing and recuperation and recovery. If you're not sleeping, it's going to put you back.
Yeah.
Matter of fact. So he said, I can't believe it. You know, the dialysis, I can see from the fluids, it's much easier on everything. I think he'd lost 9 pounds in weight. I know some of that's water weight. And the biggest thing for me was he went into work and he said that yesterday my boss came up to me and said, what are you doing? You're a different person. You are a different person. 8-9 days into it.
No drugs.
You know, no drugs whatsoever. So I'm quite proud of coming up with this thing.
That's amazing.
Deliberately not carnivore. It's more about kidney health. And then, you know, I do like daily limits. Now, I know you've been trying to nail me down. I'm not going to do that.
No, go for it, please.
But I do actually talk to people about daily limits.
Yeah.
Because this seems to work. It is to get you optimal. It's not so you're not scared of these electrolytes that you definitely need. And also, I put a link to every food. There's a food data bank, and you can then not need me, and you can do your own research, and you can put in low sodium, nitrogen, and it will tell you what.
What ticks that box?
Right. Yeah. Now, what's interesting about that is the first 200 foods that come up are all animals, are all animal-based. It's completely independent. It's a completely independent database. You put it in, and you put, I want low sodium, low phosphorus, I want low sugar, Top 200 came out like that. It's everything on carnivore.
Wow.
So, and there's no vested interest.
Yeah.
So I think...
And it's not your search engine.
No. And it just shows that if you look at the function, you look at things in a more logical way and self-test. See, people don't believe that water in large amounts, in very quick
it's dangerous.
It's not great. You can put your blood pressure up by filling that with water, taking your blood pressure before you drink it and then afterwards, and your blood pressure will go up because the fluid will go into your blood plasma and, the way...
More volume.
Yeah, it puts it up, so...
Yeah. So in terms of that particular protocol, is it from day one, cut all these out, or do you transition?
Right, it depends on the person.
Okay.
One of the things about coaching is, and one of the things about ranges is, there's no nuance. So that particular person, let's use him as an example. Like, I'm a chef, I love food, I love it. Right, okay. That's not someone that's going to go, no pun intended, cold turkey. They're not going to do that. So I said, right, well, we'll keep some of the foods in that you like. Send me the pictures of all the spices in your spice rack. We'll do that, and we'll work with what you want to do. But what I will say is, here are some sort of parameters that I want you to stick to, and we go back to that. Yeah. Minimum intake, that sort of thing. Now, some people, if you don't do all or nothing, are not interested. Right. That's the sort of person they are. They'll come online and they'll say, I smoked 30 years. I didn't want to do that anymore. I stopped. Right. If they give you that, then slow transition is not the thing, because they won't follow it, because it's not, you're not floating their boat. Yeah. So you have to say, right, okay, we'll touch. So we're doing this. That's it. You're cutting that out. You're not having that. That doesn't happen. Yeah. And because they're that sort of person, that's what they wanted to hear. Sure. And they're going to stick to it. So this is the thing about placebo. I mean, if you don't know,
placebo is a great thing.
Yeah. If we drift off into sort of, can the body heal itself if you've got the right frame of mind? Yes, it can definitely help. Doesn't, if your leg's dangling off after a car accident, you can't go, ooh, I wish my leg would come back. But, in the realm of what we're talking about, you've got to have some sort of positive attitude about it, or belief. Whatever makes that work. I mean, when you test a pharmaceutical and they test against placebo, that's a scientific study, because that's saying, let's say the drug did 50% of what it should, 50% of the cohort improved, 30% on placebo did, so therefore it's the drug doing it. I'm thinking, well, there's 30%. They got better.
That's a significant amount.
That's a
1 in 3.
That happens a lot.
Yeah.
So
even in things like Botox, actually. Yeah. I've seen studies where people think they've got Botox effects when they haven't been injected with Botox.
Wow.
Even in things like that, yeah.
Wow, that's really interesting. Yeah. Actually, I should interview you. You're much more interesting than me. That's amazing. Yeah. But so that so you've got to go into the people's way of thinking. You've definitely got
to get into their psyche.
Yeah. And it's funny what works for people. I mean, the more I know, the more I realise I don't know.
Yeah, same.
Okay. And things always surprise me. And I had quite a difficult call a couple of weeks ago where they were worried about osteoporosis. They'd seen a few success stories that I'd mentioned, and reversal of osteoporosis, which is an interesting thing. And they were absolutely convinced that it wouldn't work for them. So I got them to do what's called a mood and food diary, but I use WhatsApp if I can, and they just take a picture of what they're eating and tell me what their mood is. Really simple. That's something I've stolen off of Judy Cho, that phrase, mood and food, because she's brilliant. And that was not working. It wasn't working with her at all. And then we did a call face-to-face, and I judged her completely wrong. And she was saying, "Oh, I really need my veg. I like my veg and all this sort of stuff. And surely that's going to be good for bone health and all this sort of stuff." So I just said, "Well, what's in veg that you can't get in meat that's going to help your bone?" "Well, I don't know. It's just a feeling, right?" I get that. You look at fruit and veg, in the supermarket or wherever. It looks like it's got to be good for you. I said, "So, how did you get to the osteoporotic state that you're in? What have you been eating?" Because the answer was fruit and veg, and predominantly vegetarian. So again, I tried to switch on that sort of, well, you've got osteoporosis and you've eaten lots of that stuff.
Yeah.
So it possibly isn't the right thing you're thinking. That didn't do anything. Yeah. So I got off and I thought, I've got no idea how I'm going to get to this person because I'm doing all the nuanced stuff and it's not working. So I just sent a load of studies about osteoporosis and the ineffectiveness of vegetables. Yeah. And I just got a message back, perfect.
And that was it?
Yeah, and that was it.
Amazing.
Up and running. So there's a lot of prejudices, not from the fault of the person. I mean, the saturation, no pun intended, from the mainstream media about certain things being bad, like saturated fat and red meat, is everywhere. And it's in films and it's in sitcoms, little jokes, you got bacon and egg there, you won't be alive tomorrow, or those sort of things as little snippets of ideology and all these things. So you're fighting that as well. You've got to use everything in your armoury. I always thought that success stories that brought it to me were enough.
Yeah.
But then you realise that you have to be more convincing in some respects, which is partly why I think your channel's really going to be incredibly successful. It's successful now, but even more because you have a nice common touch and also you bring the science.
Yeah.
Now, I try to sort of be very simplistic.
Yeah.
That's what I'm after. I'm after people that go, "Oh, that makes sense."
Yeah.
The problem is, when it comes to bloods, you have to unpack what the bloods are, and the only way to do that is to explain what you're measuring. Then when you explain what you're measuring, you understand, you have to try and get the person to understand what's the relationship between one and the other. Yeah. And this is coming on to the iron panel when I was talking about
we'll go to that next.
Speculation, if that's all right.
Yeah, let's go to the iron panel.
Iron overload is a thing that is possibly associated with eating lots of red meat, but it isn't really as simple as that. So when you do an iron panel, and again, I brought notes, sorry to be prepared.
No, go for it. I love that.
I didn't want to miss something. So serum iron, TIBC, which is the total iron binding capacity, which I will explain, the unbound iron binding capacity, ferritin, transferrin, and transferrin saturation. All right, so that's what a full iron panel is, by the way. If you want a full iron panel, you need all of those things. Now, ferritin going up, is that a problem? Now, there are loads of influencers out there, say the range up to 300, that's dangerous, it needs to be under 150. Right, okay. I understand that, so the first thing I'm going to say is I get that. And the best analogy I ever heard was dynamite's safe when it's packed, all right? And you can put it in a lorry and you can move it around. Yeah. Would you want it in your bedroom? Right, so that's my analogous thing of iron wrapped up in ferritin. So when you eat iron via your diet, some of your foods contain iron, we can absorb it. there's a critical thing when people talk about iron, which we're now going to say, which not many people say, is there's another way we get iron, and that's the breakdown of red blood cells.
Recycling.
Yeah, it makes total sense, doesn't it? Hemoglobin, heme iron and globin. So it's not just about what you eat, it's about what your body's doing with red blood cells. And already, hopefully, you're making a link to what we spoke about earlier, because it's a big factor in this. So I will get the panel and I will explain to people what it is. So serum iron is iron in the blood.
Yeah.
So if you imagine like literally little balls of iron in the blood, just that isn't what it is, but just trying to imagine it for the thing we're going to talk about. So then you get a thing called transferrin. So that's transferring the ferrous iron.
Kind of ferrying around iron.
Yeah. So you've got that, okay? And that's got little holes for that serum iron. And so that's going to move the iron around in the blood. You don't really want the serum iron to be looked at in isolation. You also need to look at this transportation system. So we look at how much transferrin, which is a protein, little gaps for iron to stick into. That's that, right? So then we look at how much iron is in the transferrin and how many gaps are there. Well, that's the saturation. So we, us phlebotomists want it to be about 30%. So there's lots of space.
So 30% of the holes have iron in.
Yeah, have iron in, yeah. So that's the saturation. Right, so when we then look at other places that have the need for iron, ferritin is the storage form of iron, or long-term storage, that's what I should say.
It's the warehouse, if you like.
Yeah. So ferritin is also known as an acute phase reactant, and I need to get this bit out of the way. It can go high if you have an infection, because iron is needed by pathogens, all the baddies that are trying to attack you, and your body's so smart, it says, well, we can kill them by removing iron from their, from their food supply. We can kill them like that. So ferritin will go up as an acute phase reactant, and I do get that ever so often, where people have had high ferritin, and I say, did you have an infection? I don't tell them this connection. I say, did you have an infection around the time you gave blood? Oh, yeah. Yeah, right. I said, we're going to have high ferritin. Oh, how do you know that? I said, well, because you had an infection. That always happens. So ferritin also goes into macrophages and also into the bones. So there's a lot of storage.
And macrophages are the white blood cells.
Oh, white blood cells, sorry. Yeah.
Okay.
I'm talking to you, and I know
it's fine.
You know it. Right. Now, if you had iron overload, what would happen? Well, you would have transferrin saturation, and your body is smart, it would produce lots of transferrin. So transferrin would go up and transferrin saturation will go up. And that's a big factor when we're looking at whether you've got iron overload. So people will immediately say, well, do you test for hemochromatosis, right, which is a genetic defect? There is a problem with that. The HFE gene is obviously critical if you understand this, but there are 15 more genes that aren't HFE that can cause iron overload, and they will be missed. And this is the big problem with hemochromatosis testing, is if you're told you haven't got it, you could still have it. To me, that's like, wow. Yeah. It is a small percentage, it's only like 5% of the people.
Yeah.
But if I've had 100 clients and 5 of them...
It's critical.
Yeah, it's critical.
I guess most people just manage it by giving blood.
Yeah. It's
now and again.
Yeah. So you have to use the panel, really, and that's just an adjunct to it. So you could say, right, well, you could be tested for hemochromatosis. Come back when you've had the test and tell me whether you have or not, and then we can move forward with what we do. So, but there's still 5%. So we need to understand the bloods, and that's the big thing. Now, if your red blood cells are dying later, your ferritin's going to go up because you need more storage iron, because your body's really smart. And no one's factoring this in. No one is factoring this in. And it's really frustrating, because now what I've found is that everybody that has a very low reticulocyte count has slightly higher ferritin. And there's nothing wrong with that.
Yeah.
And because it's over 150, all 5 of those people are absolutely panicking. And it's explainable. It's absolutely explainable, because all the other numbers are absolutely where they should be.
Yeah.
but there's no clinical presentation. There's no worry. There's nothing to say you've not got enough or.
The body is so amazing.
Yes.
At self-correcting and doing the best it can with what it has available, which I think just is missed all the time. And that's why when people look at cholesterol going up, they assume it's a problem. But how do you know it's the arsonist and not the fireman, which I think we've spoken about before?
Yes. Yeah. Well, that's something that people don't talk about, you see.
Yeah.
And I think they don't talk about hemochromatosis in a way that we need to sort of accept that 5% are going to slip the net, and also that the life of the red blood cells has a huge impact, because that's taking iron around. I don't understand why it's not talked about, because that's one of the functions of the red blood cell, is to take iron around the body. Yeah.
And I think when people go carnivore, one of the things they get back, and it's in the red in terms of ranges, is the ferritin, right? But there's also trans ferritin, right? Would you be able to just talk about the difference between those things at all?
Trans ferritin?
Yeah.
Well, that's the movement of ferritin. Yeah. It's the same thing, like a boat. I didn't want to complicate it because I wanted to get that across.
No, that's fine.
But yes, I mean, there are subsets of everything.
Yeah.
There are proteins to take ferritin around the body, and like the same thing. So you're transferring iron, and you're also transferring stored iron, if you see what I mean. So it's two different things. But it's very important to not overly worry. I'm trying to keep that nice and simple.
Yeah,
if that's okay.
Sure. No, that's fine. And when we look at other minerals as well, I think you and I both agree it's very difficult to get a true reading of the actual content in the body. So when people want to look at, say, magnesium as an example, it's give me your opinion, but I don't think it's appropriate to take a blood reading of magnesium and say that's how much the body's got, because it is mostly stored in hard tissues and not soft tissues. Yeah. Are there any minerals that you think a blood test is good at showing a deficiency of?
Well, you can get tests that are slightly better.
Okay, please tell us.
So, I mean, let's nail this. In biochemistry, right, I've seen thousands, and it's very, it's just minuscule amount where I've gone, oh wow, a little bit of biochemistry is not quite right in your blood, because it is tightly regulated, as you say, and the main players like calcium, magnesium, pretty much they're going to be nailed on, because the body tightly regulates it in the serum.
Yeah.
You can do what's called an ionized calcium test, which is a little bit more nuanced.
Okay. What does that involve?
We asking the lab to do it.
Okay.
It's just looking at the sort of different form of calcium. It's, again, not that great a measure.
Okay.
I actually don't feel that you can do much with electrolyte testing.
Yeah.
Because it's, like you say, in the tissue, it's more about symptoms. Yeah. So, for instance, if someone's got leg cramps, you could, trial and error, actually, it's a good old-fashioned trial and error.
Yeah.
That's probably the best example. I'd rather talk about that because that's really relatable.
Please.
Yeah. So people will have leg cramps, and the straight away answer is either hydration or magnesium. Right now, you could do their bloods, and I have done their bloods, and the bloods say their magnesium level is fine. So that's proof positive. It is about what's happening in the tissue, which is why I wanted to go away from what you were saying, because I think we were getting more into the science rather than practical application. And you could say to that person, spray some magnesium on your calf.
Give it a good rub.
And does it go? Yeah. Right, yes. Right, okay. You were probably magnesium deficient. And yes, normally if you spray magnesium and it's a bit itchy, irritating.
It's quite normal.
Yeah, that's fine. And it probably shows you are a little bit low. But that's what I would do. I would do like a trial and error thing based on the symptom. So if it is, like I say, like a leg cramp, and magnesium doesn't fix it, then you could look at the hydration status. You could do a urine analysis, which is also, pretty interesting, which will show, what you're excreting, and you could pretty much say, well, you're not short of these things because you're excreting them out.
Yeah.
Again, not getting into levels, but pretty obvious. If your urine has lots of...
Yeah, if you give it 100 units and they pee out 99 units, clearly there wasn't a deficiency.
Yeah, and it's that simple. But I think it's one of the hardest things to actually give numbers to, which is sort of good and sort of bad. Yes, the body tightly regulates it, but what is it? I mean, 99% of the electrolyte is in the tissue, it's not in the blood. So you're getting this very poor reading anyway.
Completely agree with you.
Yeah.
And you mentioned earlier C-peptide. Could you tell us what C-peptide is?
Yeah. Insulin is made in a vesicle, and it has a very short half-life. In fact, its concentration in the blood, insulin, is very small, and it doesn't last for very long, which is surprising because the way it's talked about, you think this evil thing, insulin, is around for a long time and there's lots of it. So you have a vesicle which produces insulin. Very basically, C-peptide is the protein that is in that vesicle. So when you have insulin released, and why it's a good proxy marker is also C-peptide is released at the same time, and you don't get that from anywhere else really. So that has a long shelf life. It's in the system for a long time.
Yeah.
So it is just a great measure of insulin production because it's in the blood for longer.
Yeah.
And secondly, when you're measuring insulin has been utilised. So it's not around for very long, and also it's doing its job.
Exactly.
So C-peptide is just that proxy marker that says, right, this is how much insulin you're making.
Okay.
And then things like the insulin sensitivity, I hate the phrase insulin resistance, but the utilisation of insulin is irrelevant. We're talking about the production, pretty much like we just said about electrolytes. If 1%'s in the
which
blood,
I have here from the Keto Pro.
Yay! Good boy. But he's not Sports Direct. So it's about utility. This is, in fact, the whole of my rationale is what's the common sense here? Yeah.
And that's lost.
Yes, totally lost.
That's lost in the teaching. It starts in the teaching at university, and it is just lost, in my opinion.
Yeah, absolutely. But so it's just a very good measure of production. Then, right, you're making this amount of insulin, and we can quantify that. It is still a proxy marker, but it is the best we've got. Yeah. And then we can work out, well, is this person insulin sensitive? Are they insulin resistant? Is what is actually going on? Yeah. So I've got a wonderful bit of footage where I've taken historical data.
Is this on your channel, by the way?
It's on my channel, cool. Yeah. And we've looked at going back to 1970 for patients, and then done like an aggregate of their blood glucose and their insulin. And wow, you could have predicted these people were going to be diabetic 20 years before they were diagnosed as being diabetic. And this is actually a really big thing that I talk about. Your blood glucose measurement, and going back to Keto Mojo, is just a measurement and a snapshot in time. We haven't got what amount of insulin is needed to get that reading. Yeah. So what this video does, and I'll try and do it.
Completely agree with you, by the way.
Sorry?
I completely agree with you. You're bang on in that.
Yeah. So it shows the average blood glucose of many patients, and because it's something I've put together, it's not very official, but it's great for sort of a demonstration of the concept. And we can see all these patients over time. We've got this wonderful blood glucose. It's, it's right in the middle where it should be. I hate that phrase, but where we're expecting it to be. And then we've got their insulin as an aggregate over time as well. And what you see is there's more and more, these are all people that subsequently became diabetic, by the way, which is very important. Sorry, I missed that bit. And insulin is just rising in the background. Now, if you were doing insulin and blood glucose, I think it starts 1974. So let's say
1974, I think is a reference.
1984, you can say, hey guys, your blood glucose, you're thinking you're doing okay, but you're not. You need twice as much insulin as you used to use to get where you're getting. And you could then say, right, we need to make a dietary lifestyle choice here. We need to intervene and see if we can get the levels of insulin down while still keeping your blood glucose where it should be. But that obviously doesn't happen. And the brilliant thing about this graphic is you can just see this climbing and climbing and climbing of insulin in the background. And then you see this slight uptick of the blood glucose, pre-diabetic, which again is is
It's an opinion, but
is a thing that
yeah.
people invented to make you pay attention, and it's very arbitrary. And then you see the pancreas can't cope, and you see this big drop, and of course you get consequently very big rise. It's a beautiful graphic that suddenly crosses like that.
Yeah.
Bang, you can say that's when you were diagnosed with type 2 diabetes.
Yeah.
But actually 20 years previously, we've had this beautiful measure. Now, it's really expensive to measure insulin,
Yeah.
but it's not that expensive to measure C-peptide,
C-pep.
which is why it's pushed as a good proxy for insulin. Still, not many people do it, and it's not standard. It's something you have to ask for.
Yeah.
Now, that might bore people considerably the first time they see it, because it's like, what can I do with this? I don't know. Let's say it's in range, because there's still a range. There's always ranges around those things. What's average for people? You have it the next year, and your blood glucose is great, but that's gone up. Then you're doing something wrong.
Yeah.
But it's still only 2 data points.
Yeah.
So you need another year or 3 over a year or whatever to see a trend. And I would suggest it's possibly still going to need like a couple of years, because seasonal differences, winter time,
If you move house, move country, it's all play a
it's
big
going
role.
to make a huge difference to all those readings.
Yeah.
The more data you got, the better. And you'll be able to see for yourself.
Yeah.
And I'm not talking to carnivores here, I'm talking to people that are sitting on the fence. What you're eating or what you're doing is not doing your body any good.
Yeah, I agree. I think that it's interesting you talk about the 20-year gap. That is, those nerds amongst us, that is from Cleve 1974, the saccharine disease. And they were in South Africa. Look, I think Thomas Cleve worked with George Campbell. And they looked at exactly that, how long it took. And that's why we have that phrase of 20 years now. So it's interesting you said the same thing. You mentioned also C-reactive protein in the past. You said that was an inflammatory marker. Could you tell us a little bit about when we have inflammation, why CRP comes up?
Well, it's a signalling protein, really. So what happens is, and I want to give this a frame of reference as well,
sure.
which I think is interesting. Whenever you're inflamed, the inflammatory process is a healing process. So let's get really basic. So you're playing football, you're in goal, and someone comes and knocks into your knee, and it swells up. Right? That's the inflammatory process.
But if I was Oliver Kahn, I'd keep going.
yeah, and I wouldn't knock into you in the first place because you're a beast. But anyway, so the inflammatory process is your body saying, right, there are things happening.
Yeah.
There are things happening in this area. That's why you get heat. That's why you get swelling, because everything goes to that area. And there's more fluid there. Obviously, that's why it's bigger. There's more blood there. That's why it's hotter, because you've got this internal temperature, but it's concentrated. And the idea is that debris will go, and things that will fix yourself. Again, I'm trying to be as layman as possible to get what inflammatory things are, will be in situ to fix whatever that may be, scar tissue, whether that is just collagen, whatever it is that's needed there. That's the inflammatory process. So then there is a point where you want to try to reduce that inflammation, so that's where movement happens, and this is why motion is lotion and all that sort of stuff. It's better to keep things moving rather than let that fluid stay there. So you assist your body by doing that. Now that's why we have different signals from our nerves for a start, because there are 4 signals that go back to the brain, and the 4th one is to immobilize you. So let's say you've got that inflammatory response, and then you've got the ascending pathway, which is the signaling goes up to your brain, and then you've got the somatosensory part of your brain saying, right, we've got a signal, that's pretty bad, and it has a descending pathway, and it either immobilizes you or it keeps you going. So and that's the 4th stage of that is immobilization, which makes total sense. So you're there, you've got your bad knee, you go, oh, I'm not moving. So going back to my back, that's what happened to me. I was completely flat.
Yeah.
I had the 4th signal, and it was don't move, because if you move, that's bad. So the whole thing is mediated by different molecules that signal, and C-reactive protein is one of a part. You see, it's not
seen in isolation.
No, it's not. That's a thing that does the inflammation, because a whole host of cytokines and other things come in, and macrophages, everything sort of clears up and does all that. But it is a good marker because it reacts very quickly, and if you've got systemic inflammation, it will be elevated and high.
Yeah.
Now the range is. Someone said to me yesterday, I wish mine was completely zero, which I've not really seen, and I don't think labs are that nuanced to be able to tell you that. But the range is theoretically 0 to 5, and if you're 6, wow, you've got inflammation. But that isn't really it. Our good friend Phil Escott is always proud to say that his inflammation CRP went up to 192. So if we
while being vegan, was that?
Oh, well, he was vegan, yeah, obviously.
Yeah.
So if your range is, working in your studio, I like visuals, by the way, and that might be partly the deaf thing anyway, or
Maybe.
how I do. But anyway, if your range is 0, let's say 0, I think I'm doing it right. I'm not
Yeah,
sure
you
which
are.
way I'm going across the screen. So 0 to 5, and you want to be in there, and you're here, right? Wow. You think in your head, I've got CRP of 6, this is really bad. Now, if you're 0, 192, and you're 6, doesn't seem too bad.
Yeah.
So we have to get it into a perspective. And one of the clients I saw, and I can remember this because the numbers were just perfect for my memory. She came in at 80, and within 3 weeks it was 20.
Wow.
So we got down to systemic inflammation. Exactly, wow. But it was still 4 times worse than 5, wasn't it?
Yeah.
And she was really happy. So these numbers are sort of meaningless in the context of clinical presentation. I know I'm banging on about that, but it's true. So it is a good marker, and it is telling you there's some inflammation. It is just a protein, and it does elevate in the presence of cytokines and other types of inflammation. But it isn't the be-all and end-all, because you could have it elevated, but it's doing its job, and you don't know you've got a problem.
Yeah.
It's fixing it. And this is the nuance that is very difficult to get across to people when we're talking about like their white blood cell count or platelets or whatever. If there is any movement in the numbers, it's a reason. It's not it's not a fault.
I completely agree with you. People see these numbers and they think, I need to get that number down. No. You need to alter your phenotype, which is your diet and lifestyle, so that your body doesn't move it up.
Yeah, absolutely. Yeah.
And a lot of people don't realize that. And I think that's for me, that's one of the most important things looking at blood markers or blood testing of any kind to look at any disease. You don't manipulate the paper. You need to change yourself and what you choose to do in your life so that these markers then show you're doing the right thing, because they're not a problem. That's your body making the best of the situation. It's telling you that what you're doing is not good, and you have to choose to do better things. Would you agree with that?
Oh, absolutely, yeah. And that's why I always, not duck the question, but I always try to bring it back to a sort of relatable thing.
Yeah.
That these are just numbers, and it doesn't really matter what they are as an object.
Yeah.
Because 300 years ago, nobody knew all this.
No.
And that's my big thing. We've lost observational powers. So if you look at like the Crimean War, sort of 1850, something like that, there was, let's look at some other things. Look, the Industrial Revolution, like in the 17th, 18th, 19th century, we started to get people going into sort of warehouses and not being outside.
Yeah.
And then you got rickets.
Yeah.
You got this new disease, right? Now, people noticed that. And they went, well, you've got bow legs. Why is that happening? And why are the people out in the fields not having bow legs? There must be a correlation. So they knew there was something in being indoors that was a problem, or there was something good about being outdoors.
Yeah.
They didn't know about vitamin D and sunlight and all that. So they wrote it down, and they said, that rickets is really bad, so we need to do something like that. And then they tried different things to eat and all that sort of stuff, and they realised that the easiest thing was to get these people out there.
Yeah.
Yeah. So that was that. The Crimean War was because of Florence Nightingale. She wrote copious notes. She was a statistician as well as a sort of healthcare provider. And she was often writing, it's really strange that the soldiers that are outside in the space, like the spare space, because we want all of them under the tent, in the tents and being attended to. The ones we've had to stick out in the field they're getting better quicker and their wounds are healing quicker.
Yeah.
What is it about being outside? Well,
And you look at hospitals now.
yeah. And it's that thing that we've lost about just being really simplistic about it.
Yeah.
Well, it's because they're outside.
Yeah.
Doesn't matter. It's because let's get outside and work out why that worked anyway.
Yeah.
But of course, it's nice to know what vitamin D is and vitamin K2 and all that. It's nice to know it, why that works. But in the end, if someone came to me and said, I feel really poorly, I've been sitting in this bed for a long time, I've got two choices. I could find out why I'm feeling poorly, or I could do something to make myself feel better.
Yeah.
What are you going to do? Can you explain why I'm ill, or could you tell me how to get better? I'd be like, well, let's get you better. Yeah. And that's getting outside.
Yeah.
And that to me is sort of how I try to coach. Yeah. It is great to know it. People do like to know it, but I think in the end, it's the practical takeaways that are the most important thing.
Exactly.
So when we were talking about the sort of protocol for kidneys, it's more sort of like a fun thing to do, to talk about.
It doesn't change what you do in diet and lifestyle.
Yeah.
It's just a bit of extra knowledge if you're interested.
Yeah.
Yeah.
Yeah. And if the guy had said to me, oh, look, I don't care about why. Yeah. Tell me what to do. Yeah. I'll be like, fine. Right. Now, what tends to happen in that case, and that does happen, they get better and then they say, why did that happen? Yeah.
Same. I see the same thing.
Yeah. So I think it's a really interesting space that you're in because you're very, very knowledgeable. But in the end, what I like is you have a practical thing to do. Yeah. So like the derma rolling, which I didn't do before today because I didn't want to be all sort of fresh.
It's all right. Long way of digital, my editing team would have just smoothed it all out for you.
But if I'd have met you at 25, say, for instance, I was very wrinkled even at 25. My life was ruined by the carbohydrate, food guidelines, my teeth, everything, skin, everything was ruined. Absolutely. If I'd have met you at 25 and I said, look at these wrinkles, I think it's because I worried about my mum going and my dad dying and my girlfriend's gone and all that. And you'd have said, we'll probably make you look better. I wouldn't have said to you, oh, well, what's the science behind that? I would have said, well, what have I got to do? Yeah. And I would have done it, got the results, and then possibly wanted to know. But even then, happened? It's still possible. I mean, possibly I wouldn't. Yeah. I'd be just happy
for what you have. Yeah, exactly. Yeah. You mentioned vitamin D there. When you're looking at these blood tests, in terms of looking at the markers we've spoken about so far, there's issues with things like the estimations, the calculations. Is it actually an appropriate way to measure that in the body, etc.? Do you find those problems and those issues apply to vitamins as well as minerals?
Yeah, vitamin D is the one that I'm experimenting on myself at the moment because I find it fascinating. I call it vitamin free because you can get it by going outside, and sunlight is obviously important. We measure 25OH, so it's the inactive form of vitamin D3. And people think, well, I want the active form, but there is a big problem with doing the active form, as we were just saying, because the parathyroid gets involved and you can have false readings from it. And also people that eat a vegan diet will be able to take part, basically, because their D2 gets converted to D3. So it's like a level playing field of people across every way. So when you're doing blood tests, if you're not carnivore or specialising, it's pretty much the standard everywhere. So you can say, right, in where everyone fits, this is where you are. Now, I'm consistently low, not insufficient. And I am outdoors. I play soccer outdoors.
You do, yeah.
Yeah, I think I've got a reasonable tan and all that. I'm white-skinned. I absorb the sunlight and produce vitamin D 5 times as quickly as someone with very dark skin, which is obviously down to genetics and haplotype and all that sort of stuff. So for me, it's fascinating. And I know Richard, my co-host on Sunday, we talk about this extensively because his belief is that you don't need a high level of vitamin D, it's whether you're healthy or not. So we're on the same page. But it is interesting when people start to look at the reading. And again, I go back to how are you feeling? And I believe there's a lot of misinformation about vitamin D and osteoporosis and all that sort of stuff. So The bottom line with vitamin D is the absorption of calcium, which obviously then has to get to the bone and not be in the soft tissue. So we've talked about that. I'll go into it because I think it is important.
Yeah, please do.
Especially as we've mentioned osteoporosis. So vitamin D3, which we know about, basically helps your body absorb the calcium from the intestines into the bloodstream. And that's the key thing. It's into the bloodstream. But how does it get to the bone? And this is why you often see vitamin K2 and vitamin D3 put together as a supplement, because you need K2 because there's other proteins. People will be interested in all these things, all proteins. Proteins are so important. You get a protein called osteocalcin, which is actually the second most abundant protein in the body. Not many people know that. And that only really activates when you've got K2, the vitamin K2, which makes it active. So people say to me, we want to measure the active form, but we're going back to this. You can measure osteocalcin, by the way, but where do you stop? And what relevance is it? We want endpoints, really. We want to look at what you're doing. Does it make your bone stronger? That's what we actually. All right. So let's look at the past and let's learn from people's experience of what's worked and what hasn't. So anyway. So you've got vitamin D, that helps the absorption of calcium through the intestinal wall into the bloodstream. And then you've got these two proteins. You've got matrix GLA protein, or MGP, which is also activated by K2. So that's why K2 is important, because you've got these other proteins, but without K2, it's not activated. So one, MGP is around the arterial wall going, you're not coming in here, calcium. So it's like a sort of bouncer that pushes you along to the entrance. And this is changed, by the way, recently, but this is the mainstream understanding, which is sort of right. And then osteocalcin with K2 gets it to the bone. That's it. So it's not in the soft tissue, it's in the bone. Now, what if you eat a lot of those things and you are outdoors and you get a coronary artery calcium score of 639? Why has that happened? Because the body isn't perfect. And there's other reasons why calcium is deposited in the arteries. And there's other reasons why the arteries have problems, which aren't to do with that, but more to do with mechanics. The laminar flow of blood, bifurcation.
Shear stress, stasis,
shear stressing and that sort of thing. So when you look at where there are plaques in the blood, or in the arteries, I should say, you have to look at, well, where are they? And they're always consistently on the high pressure side of the vascular system, so in the arteries not in the veins. Secondly, they're all pretty much at bifurcations and pretty much where there's turbulence and vortexes. So it isn't necessarily cholesterol, because cholesterol goes through all of that system.
It's in every single vessel.
So it's more to do with the mechanics of your body and stress as well. So my calcium, and this is very layman's, and everyone will be annoyed about this, is my natural stent. Because if it wasn't there, I would have had a ruptured blood vessel, coronary artery. I would have definitely had that. So it's there for a reason. Pretty much like your fireman analogy with cholesterol. That's why that calcium's there. It is actually making that still function. And then obviously if you can reduce it, then what's happening is it's repairing. Yeah. So it's pretty much sense.
Now, amazing how the body looks after itself, right?
Yeah. So the reason it's activated is it's carboxylated, so that all that means is carbon, oxygen, a functional unit. I'm not going to get into all this. You can get into this.
I love gamma carboxylation.
so it makes it work. It's like if you've got a car,
puts the key in and turns it.
You add something to it, it will do something else. You add another wheel to it, it's going to look funky. Whatever. You add a fin to it, might be more aerodynamic. So it's carboxylated. Now, under certain conditions, the bone will release that osteocalcin to do other things. Yeah. And this is the body being brilliant, because you get a thing called undercarboxylated osteocalcin, and that requires a stimulus. Normally, something like exercise would be a good stimulus. And this is part of the reason why people say, I've got weak bones. Why does resistance training work? This is one of the reasons. When you put the bones under stress, yes, it is, again, mechanical. There is a mechanical thing there that's going on, because obviously if you want to lift something heavy, you need thick, strong bones, good joints and all that. But also you need signalling to make other things work. So undercarboxylated osteocalcin leaves the bone and it stimulates other things. So your gonads, your testes, it produces more testosterone. Even in women, it produces more testosterone, which explains, like weight training works there. It will then also go to the fat cells, and it will stimulate them to produce a signaling molecule. I'm getting like you, and I want to do this.
No,
but basically,
as much detail as you want or don't want.
Yeah, it will stimulate the skeletal muscle and the liver actually to be more insulin sensitive. So that's one of the other mechanisms why training or working out or movement or anything you want to say or walking makes you improve your symptoms on type 2 diabetes, for instance. And it will also stimulate the pancreas, believe it or not, to increase a little bit of insulin, which explains the insulin response when you're training, because you need insulin to grow muscle and stuff like that. Well, this is a big loop of what's going on. You've got the sunlight, you've got the vitamin D getting calcium into the blood, you've got osteocalcin K2 taking it into the bone, then you've got a stimulus getting it out of the bone, and then go into other organs to produce more insulin.
Yeah.
But increase insulin sensitivity at the muscle and at the liver. Wow.
Yeah.
Hang on a minute. We're talking about insulin causing insulin resistance, but doesn't seem like it's that simple. There's this whole thing going on here where you're improving your insulin sensitivity or getting rid of your insulin resistance without it being levels of insulin. It's all to do with other things as well.
Yeah.
And this is the problem with being on YouTube. It's all about really simplistic things. Yes, reduce your carbohydrates, you will reverse type 2 diabetes. Yeah, I think that's pretty broad a statement. If you want to know why, well, we can get into that.
Yeah.
But do you need to know why?
Exactly.
Getting outside is going to help your bones.
And nothing will change that.
Yeah.
Regardless whether you have more knowledge or less knowledge, that will always still be the case.
Yes. Yeah. Why does, so what I'm trying to say is all that stuff is basically saying to somebody, eat the right foods, eat the appropriate human diet.
Yeah.
Get yourself outside, move a bit.
Yeah, exactly. It's not complicated. it's really that simple.
It is really that simple.
Yeah.
Yes, it's great to know the mechanisms.
Yeah.
Not at one point of that 3 bits of advice did I say, your level needs to be this, you need to do that much and this. Right, now, when you get into dosage and things like that, vitamin D3, there's a thing called international units, right? Deliberately designed to scare the pants off you. So 10,000 IUs is a meaningless thing. It's very arbitrary. But let's use it. Okay, so should you take 10,000 units of vitamin D3? Well, what happens if you go in the sun? And the study I looked at was in Finland, 62 degrees north. Nobody goes to Finland for a sunny beach holiday. It's not sunny. You go in the sun or you go out in the day and sunbathe in Finland for 30 minutes, you'll get between 10,000 to 20,000 IUs of vitamin D3 or equivalent. So if the body can do that, taking 10,000 IUs should be pretty easy. Yeah. And we can handle it.
Especially if we're making it ourselves, right?
Yeah. So I don't see the utility in any of the sort of knowing the ins and outs of everything. I think people like it, but in the end, if someone comes to me and says, I want to be healthy, they're the things I talk about. I talk about the diet. Same. Are you getting activity and are you getting outdoors? And then we're on YouTube now. Yeah. Don't look at the screens. Don't look at your phone. Yeah. Try and sleep properly.
Yeah. Basic things.
Basic things.
Which aren't massive profiteering, money-making things, which is why I think they're not touted by big companies very much.
Yes.
And they will always tout, take this magic pill, this magic supplement. Doesn't work like that.
Right.
You have to take the basics first.
Yes. Now, I'm going to flip this on its head completely and utterly because I am one of those that does want to know.
Yeah.
So I am experimenting with different ways of supplementing with vitamin D to see if it actually makes a difference. Yeah. So at the moment, I'm doing like the fermented cod liver oil with the butter just to see. I've just started that. I've done my baseline. So for those that want to know about experiments, you have to be prepared to put a lot of time in and keep things very consistent. So I did my vitamin D3 levels, my 25 OH, with a dry blood test in March with a particular lab. I'm using the same lab. I've just used the same lab to do my summer vitamin D3. And guess what? It was exactly the same.
Wow.
Right. So what happened there? We don't know. So March, did we have a very bad summer? That's possibly the reason. But
it is Britain after all.
Yeah, but I was definitely out more than the previous 6 months, leading up to March. So how did I feel? Well, I felt great. I felt great in March, and I feel great in August when I did the second test. So what we're saying is pretty much what Richard Smith said. Does it matter if it's low? Because I was feeling great both times. Now, the only way to prove or disprove that is to try and raise that artificially with a supplement, and then go back and try and put a number on how great I feel and see if I can firstly increase my levels of 25OH, which is, what I'm trying to find out.
Yeah.
And secondly, did it make me feel even better? And that's it. So, there's no quantities there. There's no numbers other than I know that the vitamin D3 supplement I will be taking after I've done the next one with the cod liver oil will be 10,000 IUs and K2 as well. So watch his space. So I'll come back in a year's time, I think.
And let us know.
Yeah.
I was taking, I think you probably know this, I was taking 100,000 a day for, I think it was 3 or 4 years roughly. Calcium was absolutely fine. No hypercalcemia that was reported at all. I had no symptoms, no health conditions.
Because you took the right things.
Exactly.
Oh yeah, let's put a little proviso in here. A lot of cofactors are talked about, but magnesium's very important.
Magnesium, zinc, selenium, K2, all these things. If you're going to do high dose vitamin D3, you have to do it the right way. Yeah. And obviously, because I know I was fine and I had no issues whatsoever. Even my last blood test, which I put publicly on this channel, I had a toxic level of vitamin D3, I was told. And I said, okay, well, if that's toxic, why is it toxic? And they said, well, hypercalcemia. So what's my calcium then? Oh, yeah, it's normal. How do you explain that then? Because it's not, I personally feel, and I think you would agree, it's not how much D3 necessarily when you're going above a certain amount. It's how much D3 relative to the cofactors in order to keep you safe. But that's missed a lot of the time. And I think it'll be a long time before that becomes common knowledge or that becomes taught at universities as well.
Yeah, I think that, yes, because you've got to have, and going back to the transport system, you've got to get the calcium out of the blood into the bone and not in the tissue.
Exactly.
And you need those cofactors.
Yeah, and it makes sense because that's a number of steps. So you need a number of things to help along the way.
Yeah, and I think because you're eating well, your electrolyte balance is fine, so you're not depleting yourself of magnesium too much. Because the vitamin D receptor needs a lot of magnesium. So I think that's the thing. If you're eating appropriately, going back to that tight regulation, it is difficult to eat the appropriate amount of food that's also going to give you the nutrient density you need because of things like the depleted soil.
Exactly. The topsoil is being lost at an alarming rate. Yeah. And when we look at things like regenerative farming, surprise, surprise, when you get the animals on there, it starts to come back inches per year.
Yes. And that's a big deal for me. I mean, 100%. That really is something that commonly we run a school community, which is just, like $4 a month. It's just for people, like-minded people to talk and ask questions.
It's skool.com, by the way. It's called low carb, isn't it? Yeah.
And, that's one of the things that I get really nice comments about is, you make these complex issues really simple. Because a lot of outsiders say, well, why do you have to supplement? Well, if it's a natural diet, well, we're not living in a natural world anymore. Yeah. We're living in a world where...
Buildings didn't exist. Yeah. Buildings are not natural.
No.
Having this much lack of vitamin D is not natural.
Shoes are not natural.
Yeah, exactly.
TVs are not natural. And farming isn't natural anymore because they used to do things like crop rotation where they could have a field lay, completely fine to regenerate. And now they can't do that because of economics. So, like you say about the soil, and they're also putting in, fertilizers which are, petrochemical based, and they're not doing it for nutrients and health. They're doing it to make those crops big and easy to sell and hardy and all that sort of stuff. And then you've got even the grass is not as nutrient dense as it was for the cow. So it's difficult to get the electrolytes in.
Yeah.
I don't overly worry about that, but I think if we're going to sort of talk about it, certainly talking about high levels of vitamin D3, then you do need to make sure that you've got the cofactors.
For sure.
But I am only taking a small amount of magnesium now with the Carnivore oil, because I think it's. But you don't have to. I want to say to the guys out there, you don't have to do this. I only do that because people are interested in the content. As I keep saying, I like to be very basic, but people like to know why. Why do these things work?
Yeah.
And I think that's partly because they felt. I mean, no one's ever come to me and said I deliberately made myself poorly.
Yeah.
No one says that. So ignorance is a lot of it, but it's ignorance of the system that you're being, you are being lied to about what's good for you.
Which I think is very money driven.
Yeah, everything is, sadly.
Doctors can't necessarily go off guidelines because they might get sued. The guidelines are there because people with big wallets did certain things and sponsored certain things to come out in a certain way, which is unfortunate. I want to ask you briefly about the hormones as well. So obviously on blood tests, you can see things like testosterone levels and things. Are there any myths that commonly come up about testosterone being artificially high or artificially low at all?
Well, I laugh because bodybuilders know what I do and how honest I am. So I have to tell the labs that the testosterone is going to be quite high for some of the people because, yes, they're a little bit enhanced. The hormone question doesn't really come up that much unless it's a female worried about menopause.
Okay.
And to be honest, it's one of those weird things where, because I'm meeting mostly carnivores, and this sounds a bit glib, they don't tend to have any problems, like libido problems.
Same, in my patients as well.
So if we're looking at the sex hormones, it's only females and menopause. And even then, there is more to it than that. I suppose, like we said about thyroid, that comes up a lot. But again, that's a full panel and explainable.
Okay.
And again, it comes back mainly to diet or what's happened in the past where they've been deficient. In fact, if we could take an even bigger step back, the biggest problem I have is what people did in the past. And the biggest culprits are undereating, so calorie restriction. And when you use that term, I like to add, that means you deliberately underate micronutrients. So you deliberately had less electrolytes than you need. Didn't just reduce calories, you reduced all the nutrients that you need.
Yeah, and I think we both agree calories don't exist either.
Yeah. It's just, it's crazy. So we've got calorie restricted, we've got low fat, which tanks the thyroid.
Yeah.
Everything,
even your brain, testosterone,
everything, because you've got lack of EPA and DHA, and it's fascinating to me that people don't do that joined up thinking. So with the thyroid, so the functional units of the thyroid can store up to 50 days worth of thyroid. That's that sort of average. 50 days worth. Well, I have people coming to me that don't have enough for the day, right? So they've been so starved of the essential nutrients to build up the stocks that the thyroid's given up pretty much and can't produce it. In gallbladder, we can't actually come back to that. But yes, stick with the thyroid. So when people start eating this way, it's really common actually for people to say, when I started, I couldn't get enough fat, I couldn't get enough food. And after 6 weeks, I'm not as hungry. Is that a problem? I'm like, no, it's not a problem.
Yeah.
Your body was saying, thank you very much. We really needed this. We're going to build up our reserves. It's a bit like when when you're building a house.
Yeah.
If someone said to me, we're going to build these studios, but we're going to restrict the bricks we're sending, and we're going to restrict the plaster and restrict the nails. That's your restricted, calorie deficit type diet. I would be like, oh, well, the studio's going to be a bit naff. I really would like actually a surplus. I'd really like too much. and then can I send some stuff back?
Yeah.
Well,
That's a great analogy.
Yeah, and it's, this is what we've done. We've restricted calories, we've restricted micronutrients, we've restricted salt, fats, essential fatty acids. The body's done well to get you where it is.
Yeah.
It's done whatever it needed to do. You've lost some hair because it doesn't have enough nutrients to make the hair, so it's made enough, or it's just thought, well, we don't really need it, and it's basically said, you're going to have to live day by day with your thyroid hormone because we can't do any reserves because we need to supply the heart and we need to supply the liver. The two big players need a lot of energy. We need a lot of proteins and fats. Without those things, we can't survive, but we can survive without hair. We can survive without 49 days worth of hormone in the thyroid because we'll do it one day at a time.
Yeah.
And people don't really understand that until it's sort of explained to them what they've done.
Yeah.
And they will say, well, I was a yo-yo dieter as well, so I lost a lot of weight, then I gained a lot of weight. It's good, isn't it? I could lose a lot of weight. I'm like, well, yes, but surely the inevitable outcome of constantly losing weight is you will constantly gain weight because your body is saying we need more proteins, we need more fats.
Yeah.
And because you've dipped down, and going back even to the analogy of the blood glucose, you've got this yo-yo dieting. What we want is that nice straight line where you eat enough proteins, enough fats, you have enough electrolytes, you have enough salt, everything that your body needs, and maybe a little bit of a surplus every so often. It doesn't matter. It doesn't.
We've
really
got kidneys for a reason.
Yeah, and the Kelly Hogan. I don't like to name drop. I don't know Kelly, but I know she's very popular in the carnivore space, and she chimed into an Instagram thread. What's the biggest problem you encounter in coaching? She said, undereating. And I just messaged and said, that's exactly what I'm finding. People are scared to eat.
Been
How
brainwashed.
crazy is that? Yeah.
Yeah, completely
Crazy.
agree. So when you're coaching people, what would you say are the biggest misconceptions or biggest brainwashings that you need to reverse when they come to you to come into this way of eating?
Yeah, we use that phrase. One I use as a joke is you've been brainwashed.
Yeah.
Because, whole wheat bread is great compared to white bread. And that's a big marketing ploy that they use, that they will take something that's extremely bad and make something that's not so bad, but sell it on the health benefits of that marginal difference, not in comparison to everything else. So brown bread is only better because it's, I think on the GI index, white bread is like 80 and brown bread is 78 or something.
Okay.
So it lowers it raises your blood glucose less. Brown bread does. Well, great. But compared to butter, which is like 2 on the scale, it's rubbish. Yeah. So I suppose the most common thing is what I just said is how can I eat this much and not gain weight? Now, yes, everybody can have too much. Too much is too much. Yeah. Too much water. Water isn't dangerous in itself. It's actually pretty good. But you have too much of it, it's dangerous. So I think that's one of the things you have to say to people is you've got to eat the appropriate amount of food. And if you've come to me and your thyroid is not working or you've lost your gallbladder, we've got to make sure that you're eating appropriately for what your needs are. So that's the 2 most common ones. Undereating is just endemic. I mean, it really is. That I can't eat more than that. I'm just going to gain weight. It's going to be bad for me. And I'm always trying to bring it back to, what did you put on your health and activity profile? You put that you got osteoporosis. That is a sign of malnutrition. Yeah. Your thyroid doesn't work. That's a sign of malnutrition. I'm excluding crush injuries and accidents and stuff like that. I'm just in general. Whatever's the problem is a sign of undereating. Right, now people are going to go, well, what about the obese people then? That's not undereating. That's undereating the wrong, the right, that you have undereaten the right things and overeaten the wrong things. Yeah. So, like I say, the specialist practitioner in obesity and diabetes was done because people thought that they were the same thing, but they're not the same thing. So somebody can be obese and malnourished, and they find that a really weird concept at first. So some have a DEXA scan, for instance.
Yeah.
And I'll say, you know, you're quite big now, and your bones are really struggling, but the bone mineral density is really poor, and the amount of muscle you have is really bad. So we need to get you to have more bone density and more muscle, which will involve eating more of the right things, which are like protein and essential fats. And we need to get rid of the stuff that's making no structure, so we need to get rid of the carbohydrates. And immediately what happens is that obese person sees a lot of water weight go.
Yeah.
That is a great kickstart because they see a difference straight away. But I always make it clear, it's going to be a lot of water weight. It's not necessarily fat.
Yeah.
So I think it's a re-education of what a body composition actually means.
Okay, so you find people don't really know what that is.
Yeah, they don't know. They just look at themselves in the mirror and say, look, you know, I'm fat, or I'm skinny, you know, or I look underfed, you know, whatever it is. That, you know, obviously there's people with body dysmorphia who think they look all right, and I have to actually say to them, you are too lean. You are too lean. So understanding all of that, I can't give you a tick box of 3 things because it is very nuanced.
Yeah, and everyone's different.
But it is not understanding some basics, I suppose, which is your body needs protein and fats and it doesn't need carbohydrates.
Yeah.
And you need to be outside and you need to be in touch with nature, which sounds very woo-woo, but it is a fact.
Yeah.
You know, we're designed, and we wouldn't have this elaborate, beautiful, elegant mechanism to convert light and heat into something if it wasn't meant to be.
Agree.
You know. So I feel it just, in the end, I suppose you sum it up as re-education of what a proper human diet is. And I know that Ken Berry started that phrase, but it is brilliant. It encapsulates what we're talking about. What should we eat? You know, you don't have lions looking at cows going, that grass looks really good, and look at the size of that cow. I think I'm going to eat grass, because it's not appropriate. Yeah. It's not the lion, you know, the appropriate lion diet, you know. Yeah. Lions eat what they eat. Yeah. And then, you know, if you go back to calcium, for instance, just use that as an example. Where do you get calcium from? Well, lions don't have calcium supplements. Yeah, exactly. But they can make milk. You know, the lioness can make milk. They've got great bones. You know, you don't look at a lion and think, well, that's a weak thing. Yeah. You know, so you can, from red meat, get everything. I agree. And they are a great example of that, I think. And it's just trying to answer your question, really. I think just re-education. I think they have, yes, they've been brainwashed to believe that cereal is more healthy than red meat, you know. And what about like misconceptions? Obviously, they will come to you and they'll think carnivore is this, whatever their image is. Mm-hmm. Some of that will be right, some of that will be wrong. What do you think are some of the biggest misconceptions about the diet when people come to you? Do they say that, you know, it's too much meat? Do they say that it's going to be boring? I think that is the first thing. Not enough variety. Okay. And depending on the person, I always answer it in one or two ways. So I say, okay, what? And this is already pre-done actually, because I do ask what do you eat, but it's always good to do it face to face. I say, what do you have for breakfast? Well, I have cereal. What day do you have cereal? Oh, well, every day I have cereal. Might have porridge. Right, okay. And what else? Well, no, it's just that. And what do you have for lunch? Well, just a sandwich. And before you know it, they can tell you 5 different foods. Yeah. And I say, does that sound like variety to you? Yeah. You know? And also, is it getting you where you want to be? So I think the variety one, my meal planner has over 200 recipes and I've only scratched the surface. You know, there are so many different ways to do everything. Yeah. You know, and it isn't just about Sean Baker's big chunky steak, you know, with a machete, samurai sword that he uses. Yeah. No, it's a beautiful way to eat. And you can have eggs, and you can have poultry, you can have fish, you can have shellfish, you can have pork, lamb, chicken, duck, wild animals, cheese, you know, whatever. And how long do you normally take to transition people into properly carnivore? That's a good question, yeah. You've done this before, haven't you? That's a good question. I think what I said earlier about the personality, some people need that slow transition and some people just want to dive straight in. Okay. But they always, if they dive straight in, they go in with their eyes fully open, like, wow, you might have some side effects because it's a huge shift in your gut microbiome and your lifestyle and everything.
Okay.
But so it's more appropriate to the person, what's going to work for them. If you sort of broaden the question to how long does it take for a person to transition and feel comfortable in this way of eating, I always have the stock answer of like 26 weeks plus or minus 6 is on average what happens. And I always use like the person that was the quickest, that somebody within 7 weeks was off their diabetic meds, completely and utterly unbelievable, life-changing. And the worst situation I've had is 1 year.
Yeah.
Now, that one was really interesting because at year 1, virtually, 365 days later, she messaged and said, I can't believe how fantastic I feel. And she was an endurance cyclist and she was wiping the floor with everybody. You can't believe the difference. Absolute, become
Athletes are interesting, I think, because they're a difficult bunch of people sometimes to speak to. And I'm speaking from experience, if you told me this years ago, I'd just look at me like I'm lifting all this, like forget it. But they don't realize how much more they could lift, or how much further they can cycle, or how much longer they can keep playing on the pitch when they switch up. Do you find that athletes are a little bit less open-minded, or more so perhaps?
I think anyone that's come to me is open-minded.
Okay. It's like a prerequisite to come and see you, I guess.
Yeah, because it's a subset, isn't it?
Yeah.
It's like a dentist saying, you know what, everybody's got really bad teeth.
Yeah.
Because that's what you see. You don't go to a dentist.
Exactly.
So I would have to say everyone is pretty much open-minded. Yeah, okay. There is a little bit of resistance, as in my spouse, partner, husband, granddad, whatever, thinks I'm mad.
Yeah.
But to be honest, there's a lot of real raw. They think it's crazy, but they're going to give it a go.
Yeah. Do you find that athletes need to transition differently to non-athletes?
Yes.
In what way would you suggest?
Well, it's because sometimes there's a dip in performance, and I think it's more a mental. You've got to be prepared to take a couple of steps back before you can take 3 steps forward. And that person I just mentioned would be absolutely it.
Yeah.
Because they've gone from not moaning, but being really concerned about what's happening with her body and sort of the transition period and how long it was taking. And
how long would you say?
Which she took
performance?
A year. But normally...
Obviously, the whole year was dip in performance as well.
Yeah, everything, yeah. But once it had clicked, I mean, there's no stopping her. I mean, seriously, I think, this person could be professional athlete, beyond belief. But anyway, in the main, I think within about 6 weeks, people have got it.
Okay.
I'm talking very across the board, very average sort of results where they get it, they like it, they've worked out how to cook, what to say to people, which is a huge thing to the naysayers who, you've got to have fruit and veg. And the easiest way to cure that is to say, tell them this thing. When they say you've got to have fruit and veg, just say, why is that? They don't really know.
No.
They won't have anything to say.
Yeah.
And it will just be because XYZ said it. There's nothing in it.
Well, I don't want sugar and fructose every day. I'm not interested.
No.
What about the bathroom issues? I know some people, when they transition too quickly, they're in the bathroom for a bit longer than normal, shall we say, at the beginning. How do you manage that in the beginning for people?
Right. I may be lucky because I don't have that many people that have that problem. And maybe that's because I am picking and choosing how they transition. Maybe.
Sure.
Maybe. I must stop saying Right. Let's have a think. If you can believe this, I mean, many people will have one issue and it will be the other one a week later. So they might say, I feel constipated rather than diarrhea. And we'll talk about why they feel constipated. So we'll put that to bed first. Are you constipated or are you just going less?
Yeah.
Which is often a thing they're thinking is constipation, but it is the fact that you're producing much less waste. And when it's settled down, it will go the complete reverse, and they'll be moaning because they've got diarrhea.
Yeah.
And that is explainable by the gut microbiome changing, hydration changing, all those sort of things. I don't feel it's a big issue compared to many other misconceptions.
Okay.
I think the biggest issue is like the social pressure.
Yeah.
Feeling that you're odd when you go to the restaurant, not being able to partake in social events. That seems to be my clientele, the biggest thing they worry about. If it is a toilet issue and it is constipation, I have the joke that I always use of magnesium citrate. I call it magnesium shit rate because
I've not heard that one before.
because it works.
Yeah.
And if you really want to get the thunder rolling, then you do more than the dose it says on the thing, and it will work.
Okay.
I'm glad that made you laugh. If it's the other thing, if it's diarrhea, more often than not, that's a fat issue. They're not absorbing the fat.
Yeah.
So we need to look at smaller meals with a bit more frequency for a bit, so they can become fat adapted, and then it's not a big problem. If they have no gallbladder, which tends to go hand in hand with what I've just said, I have to then educate them about the production of bile and why that's happened, and how not to worry about that, because the duct that's left becomes like a surrogate gallbladder, and it will still produce bile. And then we talk about that. Now, that's an interesting one, because once you get into the chemistry and you get into things like taurine, which is essential to make bile, and it's an amino acid in meat, they tend to like that, because I often say, look, many people think food is passive, like you stick it in your mouth, it ends up in your stomach, and it's acted upon, but it also sends messages out to regulate, so the body knows how much, how acidic the stomach needs to be, how much bile is going to be needed. It's not all random. Yeah. There are signalling backwards and forwards. So we really know that taurine, which has been in interventional studies, that means, for people that don't know, you put it in, see what happens, and you take it out and see what happens. So you actually can say, is that thing that's doing that? Well, that produces more bile, and it produces better stomach emptying, which is important as well. Obviously, more regulation of stomach acid. And stomach acid isn't set at a level. It changes throughout the day depending on what the body wants it to be. And taurine is a really good modulator of that. Yeah. And also the cleaning up aspect. Dr. Eric Berg, who annoys a lot of people, but I still think is great, uses the phrase about bile being the detergent, the thing that cleans out your small intestine, which I think is the easiest way to explain it. I think it's great. So bile is really important. So is cholesterol, because it's a component of bile. And the amino acids like taurine will help, all of those things. And people do actually quite like understanding that whole mechanism of demulsification of fat, and why it's ended up in the toilet, and how we want to not do that. So I think that's an easy one to talk about.
And what about sleep? Do people complain about sleep issues when they're transitioning in?
Yep. And again, it's a weird spectrum of as I said earlier, people start to see their sleep improve, and then they misconstrue that they've got too much energy because they're not sleeping as much, even though their sleep quality is better. And they complain, I get to 5:30 and I'm up. And I say, well, actually, that's not bad. And many people would really want that amount of energy. Oh, yeah, but I've got too much. And they've lived their life in such a sort of dirgy...
which they thought was normal all that time.
Yeah. This is normal. Yeah, exactly what I say. I just flip it on its head and say, what? When people say, oh, you look quite good for 60, they say that to me. I say, well, actually, this is possibly what 60 should look like. Yeah. Because people of 60 in your head have eaten the wrong way. I'm not saying I look great. I know I'm wrinkly and all that sort of stuff, but... Yeah, so when we talk about sleep, I always say, do you feel rested? Do you feel that you need to sleep then? Yeah. Now, some people will always say, yes, I do actually. I need to have a nap in the afternoon. Yeah. I think that's down to, say they're doing 2 meals a day. Protein needs 5 times the amount of energy to process compared to, say, carbohydrates. Also, that's a natural physiological thing after eating to feel a little bit sleepy. So I don't think it's a big problem.
Okay.
You can push through it, certainly if you're at work. You know, you can't sleep in the afternoon, obviously, unless you're at the post office, you'll get away with it. But it's natural. You know, if, again, using like animals as an example, you watch a wildlife program, they have a big meal. Lions be a great example. They have their meal and then they just go and stretch out under a tree. Yeah. So it's not the world's worst thing, but because, as you said earlier, we live in an unnatural world with all these constraints on, you can't do that if you're working, you know, in a shop and you've got to go and do a bit of retail. You've got to man up or woman up or whatever you want to say. You know, you just got to do it, get out there.
In terms of looking at these markers, obviously, I think we both have very similar views. We're not a fan of the normal ranges. We want to look at things in context and things. What do you see the future of blood testing as? Do you think there's any improvement in that aspect? Do you think there's equipment or facilities coming which can be more accurate, better calculations at all? Or do you think things haven't really changed and they aren't changing?
Well, that's a great question. That's the best question you've asked. that is a really good question, and that is the biggest bugbear. So thank you for saving that to near the end. I'm guessing that's near the end. We've got to firstly look at interpretation of what we've already got. Yeah. Right. Because it's there. It's an infrastructure. There's too much money invested in it. So let's look at what we've got, and instead of just going, that doesn't fit, I think we need to look at the context of why is that person in that number? Is it something to do with their lifestyle? Okay. Is it their diet? And that's exactly where I've got to. That's why I wrote the book, the Guide to Blood Tests.
Which
in the context of this way of eating. So
there we go. He hasn't asked me to bring this on, by the way. This is my own copy that I paid full price for. Thoroughly recommend if you want to look into all the things Stephen's mentioned today and understand how they work. You know, there's all sorts of sections on lots of different blood markers, lots of different panels, and it's available on Amazon as well.
It is. Yeah, success stories and everything as well. So we need to look at interpretation. That's the first thing, and have more nuance to it, because if you've got 150 blood markers and 149 all improve and one goes up, really, is there a problem? Or are we looking at that one marker wrong? I think we just need to twist it on its head and say, well, maybe the way we're thinking about these numbers is wrong. And that, using that example, that's brilliant of me. That's a perfect example off the top of my head, because it wouldn't make sense for 149 markers to all improve and one to get worse.
Agree.
I just couldn't see that. The odds, it could happen, but it's unlikely. I think we need to start throwing out some of the old technology and some of the old stuff that was only done because it was a workaround because we couldn't measure it. So, for instance, if we use cholesterol as the best example, if we're going to have to stick to this fraudulent claim that cholesterol causes heart disease, which has been debunked, and it's still 70 years ago when two people from the Sugar Foundation, two researchers, were paid to say it was.
I had a doctor ask me literally yesterday about LDL. Oh, it's got to be causal. How can you say it's not? Just even after all this time, it's still not sunk in.
So that's what needs to change. But the point I'm making is it isn't. So we need to change the way we test. Yeah. So if you take the nuclear magnetic resonating tests, where you're looking at the plasma and less at the red blood cells, and doing the protein fractions for LDL, if we're going to talk about it like that, let's at least do it right. I think that's what I'm saying. Yeah. At least get the practical elements correct, even if the theory about what the problem is still wrong. At least we've got decent numbers. Yeah. All right, and then that might lead to a little bit of brains being opened and people thinking about it differently, I think. Yeah. Because if you look at fluffy and buoyant and small, dense and oxidized, they're still lumped in together. So if you increase the fluffy, buoyant, and decrease the small oxidized, and you do the old-fashioned way of measuring, it's still going to say your LDL's high. Yeah. Even though the proportion, going back to that 149 and 1, you've taken all the dangerous oxidized things down and you've moved the fluffy buoyant up, that's not even reflected in the LDL calculation. So we've got to move away from that. That's definite. And we've got to look at, like I say, the filtration rate for people in this way of eating. It's got to be changed. You've got to do a different test.
Definitely.
I think you've got to do the cystatin C. The HbA1c needs to be somehow linked to the reticulocyte count. We've got to look at the age.
Yeah.
Because there's other telling marks, like MCV and RDW, which is basically about the average size and the average width. The thing I've been saying lately is all that's telling you is your very old red blood cells are a bit gnarly and a bit old. Yeah. That's what it's telling you, because there's a bit more variation in size and concentration. So there are many different things we can talk about to actually improve how we look at bloods. I'm not the only one that's talking about that. I know Amy Berger, I think, did a great thing about 2 years ago on YouTube about it. And I think that's the way ahead, to look at it with a bit more current knowledge. Yeah. And like you said about ferritin and all that, we've got to look at, is ferritin going high because our supply of iron from red blood cells is shorter in short supply because they're living longer, so we're not breaking it. So all of this just totally makes sense. So we've got to look at it as a holistic thing rather than one marker's up. We've got to do something about it.
I think people don't appreciate the guidelines, not just for blood testing, but in any medical discipline. There is no relationship given between those guidelines and what we're taught as a function of what they're eating. So even if someone's got completely different diets, they still follow the same guidelines. And it's extremely odd. I don't understand that whatsoever. When you're eating something different and everyone's problems start to go away on this particular diet, why would you give them the same guidelines or recommendations as someone who's on a completely different diet? And I think that's going to take a long time, if ever it happens. Right, I agree. I think that's one of the biggest issues. Is there any particular lab that you personally think is better than others, or type of lab that is better when it comes to blood testing and giving the full iron panel, the full lipid panel, all those sorts of things?
The best lab is the one that if you contact, they listen to you.
Okay.
If, for instance, I don't have an affiliation with anyone that I talk about. So Medichecks is very good in the UK.
Yeah.
But they do lack a few things that they won't test for. So not for any other reason, probably other than profit, I think.
Okay.
So they're pretty good. Medichecks. I use Neovos for the dried bloods, which is, strangely enough, I looked all around the UK for somewhere to do vitamin D testing. And
so could you explain what dry bloods is for the viewers? Could you explain what dry bloods is for the viewers?
Yeah. You can take blood in different ways. You can do live blood, so you can actually see what's going on, see whether it's clumping and stuff like that. Very expensive. You won't get that easily. So then you do sort of the normal venous draw, which goes in a tube and goes off to the lab. Or you can do a finger prick and you can drop some blood onto a thing. Yeah. So that's a dry blood sort of thing. Right, and that's a really inexpensive, cheap, quick, however you want to do, but you do end up with cuts on your fingers, and it's just convenient. So as I was saying, I was looking all around the country for someone to do the quick vitamin D and omega-3 and gut test as well, which is poop sample, and the one that came out the best for me, weirdly, the researcher lived in the street next to me. So I was looking in the whole of the UK. And it was right on my doorstep, which is pretty interesting. Right. So but if we broaden it out to people in the States, I mean, if they're just great. I mean, the labs are better in the States. They do offer more. You can get totally in depth with it. You can do lipid peroxides and so many other tests that we tend not to do in Britain. There's a lot more biohacking ability out there. So I don't think there's any particularly bad labs.
Okay.
The other thing is, I suppose, if we're going to talk about that, is ranges. Yeah. They are different lab to lab.
And country to country.
Yeah.
Yeah.
And I think you need that explained, or at least to understand that, because actually it sort of, in a way, highlights the mockery of it, because if you have one set
It's only the same person in 2 different countries.
Yeah.
We put on medication or not on medication.
Yeah. Yeah.
Just think about that for a second.
Same blood, yeah.
Yeah, exactly.
So what's going on there? So I think you can look into the politics and are they in the pocket of the pharmaceutical company? But in the end, it's a good service for most people. But the biggest thing is to get the right interpretation.
Yeah, of course.
And that's where hopefully I come in, or people like me who understand this way of eating.
Yeah, and books like this.
Yeah. Well, it just opens your mind up. I mean, I talk about the HbA1c in a bit more depth there. I talk about the eGFR a little bit more in depth. I talk about LDL and a little bit more in depth. So the main ones we talked about, and I think when I rewrite it or do the second edition, I'll add my hypotheses or my speculation about iron and ferritin, because I think I've got enough detail personally. And we'll also talk about reverse T3. But I think it is about looking at them in a different way and forgetting the old knowledge. Yeah. You know, it's like, you know, when a football team changes a manager, you can't go on about, well, how they used to play was this, how they could, because it's irrelevant. It's useless, we've got new information, we've got a new person at the helm. So let's look at what's going on now and use different metrics to test whether that team's good or bad or whatever. And I think that that's a terrible analogy, but just...
I know what you're trying to say, yeah.
Yeah, it's frustrating because I see influencers that I used to really respect and they're just so dismissive and they just say, oh, I'd like to see it at this level, this blood, or they should be here. And I'm thinking, well, where does that come from? Why are they saying that? Because they haven't mentioned any clinical relevance to that statement. Yeah. They're just making an assumption based on not false information, but information that's not relevant. If you are looking at running, 100 meters in a certain amount of time, would you look at the Olympics as your starting point? Right, okay, all of those 8 people ran the 100 metres in less than 11 seconds, right? That's where I'm going with that. Yeah. Right, I'm a 60-year-old man who doesn't sprint. Well, that doesn't make any sense to me. So I've got to really go and look. A 60-year-old man...
What's the context?
Yeah, who haven't sprinted for a long time. Yeah. How do they start off, right? So let's say they take 30 seconds, right, to run it on average. A 60-year-old man who's never run 100 metres. Right, and I go and do it, and I'm 35 seconds. Yeah. Well, wow. Okay, that's a relevant population. Right, well, maybe I've got to look at the fact that they all eat carbohydrates and they're faster than me. Yeah. Right, so I need to find a population of 60-year-old men who are carnivore. That's what I actually need. Yeah. Right, okay. Oh, they run it in...
8
seconds. Right. So I need to really up my game. Yeah. Brilliant. It's just, to me, it's so obvious. Yeah. That the input, but then you see, even yesterday, I had somebody tell me that they were diagnosed with diabetes, and the doctor said it's nothing to do with diet. Nothing.
I've seen professors, heads of departments, who are in denial that diabetes is linked to diet. And it's just astonishing that they reach these levels in academia and their career with such a lack of knowledge. It's unbelievable.
Yes, but you can immediately say, well, then how do you explain when someone changes their diet,
it goes
reverse diabetes, and they don't change anything else?
Yeah, unbelievable. Yeah.
To me, that's why I do try to keep things layman's and relatable, because in the end, that's all you need.
Yeah, you've got to democratise the knowledge.
Yeah, you don't need the blood labs. Yeah. You don't need to understand the GLUT4 transporter. You just need to know that if you really genuinely think food causes diabetes, then it doesn't cause diabetes. Answer me this. When you remove that food, it goes away. You've got to explain that. Yeah. And they can't, because there is no explanation.
And it's not a statistic. It's a person, like a real person, literally right in front of you.
Yeah, there's thousands of them, hundreds of thousands. I've got a small practice in the UK. I'm not a big player, so I've got over 1,000 clients. Like I say, so many have reversed their type 2 diabetes. But, you look at Sean Baker's Revero website. You type in reversal of diabetes or YouTube.
Yeah, exactly.
You know, and you will see reversal of diabetes. Now, this isn't even pushing this way of eating, is it?
Yeah, exactly.
There are people reversing it, just changing certain things, like taking out processed foods and Coca-Cola and pizza and stuff. So, yes, it's definitely diet related. I just happen to think that this diet is the best way to reverse it with all the other benefits as well.
Yeah, yeah. In terms of understanding these sorts of things, obviously you've got this book of yours here. Could you just give us a little bit of knowledge on the other books that you have as well?
Oh, yeah. Okay. Well, I want to just explain to people why I had a sudden thing where I put a few books out. I keep copious notes. I'm always taking notes, and I just put them all together to make different books. So I've got the Guide to Blood Tests. I've also got a simple one which is called How to Be Carnivore, which is really just a guide to what you can eat, what you can't eat. Well, you can eat anything you like, but if you want to be carnivore, how to go about it, and all the things pretty much we spoke about today, as in transitioning and toilet habits and the common things that come up. I've got a cookbook, because people say about the lack of variety, and that's pretty good. I'm really happy with that. I think a lot of people love it. And that works in a pretty simple way, as in there's more complicated recipes, and then as you go through the book, it gets easier and easier, or more carnivore, until you end up with some real simple recipes.
Steak in a pan.
Yeah. I mean, but I've got great recipes for like carnivore lasagna, which is really good, and all these other things. Right.
I think Maria Emmerich also does a lot of keto cookbooks. And
yes, she's great. Yeah, I've had her on my channel, and Craig, and they're very, very good. And partly the inspiration, actually, because she's always talking about you can make this food so wonderful, and she gets a lot of stick about it. Yeah,
she's really great.
Yeah, and I got flamed for having her on, and I don't like that. I'm not an echo chamber. No. I'll have people I like. Yeah, exactly. We spoke about that in the car, didn't we?
Yeah, we did. Yeah.
If someone fits, I'll have them on.
Yeah.
Don't care. Just if they've got something to say, I want to hear it. It doesn't even mean I agree with it all the time, but I just want people to come on. So there's that. I think you're surprised how many I've written. I've got one about diabetes called Diabetes Decoded, which is about diabetes, type 1 and type 2 and other types. Because I often get...
Is that kind of how to understand it, or how to even try to plan your life to try and reverse it?
Both. Yeah, okay. It sort of explains the mainstream view of it, and then we unravel that, like we've just done. Yeah. You know, and then the complications of it as well. So, neuropathy and retinopathy. Why is that happening, and how to manage it the best? So we talk about type 1 as well. So that's good. And then I've got a couple of little nuanced ones. How to grow muscle, carb-free. So our good friend Jonathan is always proud that I never cross-sell, as he calls it, because he's got the bodybuilding Bible. He's the man if you're looking at bodybuilding. It's not a bodybuilding book as such. It's more about growing muscle without carbs. And it's a bit about the science of how that is possible, and also how you can actually do it. If you're looking for bodybuilding, Carnivore Muscle is the one to go to for that. I mean, I can do the bodybuilding, but that's his thing. Right, and finally, there is one about the fat loss science when we talk about the insulin model rather than the calorie model. We talk about insulin. So I've done that as well. Yeah. And it's not sold that much because I think it proves my concept that people aren't that interested in the whys. They just want the results.
What do I do?
Yeah. So the How to Be Carnivore has been very successful. The Guide to Blood Tests has been very successful. I like the other ones. The diabetes market is flooded with stuff about diabetes, but I do question the quality. I don't like saying that because people put effort in and they truly believe what they're saying. But most diabetes books make me tut within about the first 5-6 pages because the advice is terrible.
So it's not complicated at the end of the day. Yeah. And also, obviously, you help people transition, you coach them into this sort of thing. How do they get in touch with you to do that? What does it actually look like when you have a new client come in? What is it? Do they come to see you in person? Is it online? Like, do you ask them to bring certain things with them in the first appointment? Talk us through a typical sort of journey when someone comes to you.
Okay. So you can use the website to contact me, the ukcarnivore.com/booking. If you've seen this and think, I'm going to book him straight away, which you can do, or you can look on the website and it'll tell you what the process is. I can tell you now what the process is. I always insist on an online health and activity profile where you would give me as much information about your situation, what you eat, stress, everything, as much as you can tell me. That's what I want. So then that's sent to me 24 hours before we do the consult. If you've got bloods, then you just send that via email. It's all secure. It's all private. You just send it to my Gmail, believe it or not, and that does work. And I go through the bloods the day before. So it isn't just a half-hour consultation ever. I mean, that's what it is. Face-to-face, you have 30 minutes. But I put the work in beforehand. So
same here.
We're not doing fact-finding for 30 minutes. We're actually like, right. Now, in saying that, I always like to have the person talk to me a little bit. So there will be a little bit of, right, thank you for the form, thank you for the bloods. Why did you book me? Just in a nutshell. And that is more telling than all that stuff. So it's very consistent with what we just said. All that data is fantastic, but hearing someone makes a big difference, a huge difference. Now, I use Zoom. I don't do face-to-face. Zoom is good for me because I can put subtitles on because I can't hear. And I can have equipment to make sure that I can hear everything you say. I'm not shy if I don't understand what you're saying, if your accent's really difficult. I will say, I didn't get that. I won't nod and go, not really hear you, right? So that's relevant because I do have people from all walks of life.
Sure.
And
so you treat people from lots of backgrounds, places, countries maybe.
Weird accents and stuff like that. Second language is English, third language is English. So I can do all that. And actually subtitles really help. I think that because I do that, it might put me ahead of other people. So that's how that works. Now, you can have other things. You can do like a block booking of 5. For the moment, I've got an offer, which I've been running. It's very popular, where you can get 5 sessions for the price of 4. I like that because then the half hour isn't rushed.
Yeah.
But for the person, there's that accountability.
Yeah.
And there's always questions. As much as I try to do it in one call, if I've only booked one call, I don't think 30 minutes is enough.
Yeah.
But I do understand people's budget. So if their budget only goes to one call, that's fine. I get that. I offer my personal WhatsApp. So if you don't know your quantities, you don't know if you're eating enough or you're eating too much, as I said earlier, I do like an online WhatsApp mood and food diary. So just take a picture of your food, you send it to me. You haven't got to write anything unless you want to. And you can just do that. And at the end of the day, even sometimes as you've done it, I will acknowledge that I've got it, give it a thumbs up. If there's something drastically bad, in inverted commas, like you're under eating drastically, I will point that out very quickly and say, wow, is this all you eat? Or are you not taking pictures of other stuff? Yeah. Invariably, it's I'm not taking pictures of other stuff. So, like pizza or whatever, they feel I'm going to tell them off about, which is not what it's about at all. And the process is to look at, the key question in my health and activity profile is, what do you want to get out of this coaching?
Yeah, what are your goals?
Yeah, that's it. So if they say, I'd like to lose a little bit of weight, that would be the primary goal. But I will always drill down as to why is that important? Is there anything else? Normally, when it's weight, it isn't weight. It's something else. It's like, well, I want to lose weight because I'm not very confident around people.
Yeah.
And I'm like, okay, why are you not confident? Well, I don't think I look good,
It's the same when people come to see me for, say, dermal fillers or skin issues or something like that. It's not that they want to get rid of the skin issue. They want to be able to take more pictures of themselves.
Yes.
Get pictures of their kids, things like that.
So we try to understand the reason why they want to do it.
Yeah.
And that's how that works. I have a meal plan as well. If you're not interested in talking to me and you're like, well, how do you make carnivore interesting? I do that. And so every week you'll get to your specifications. So let's say you can't handle dairy, you don't like pork, you won't get Greek yogurt and
bacon and yogurt sandwich or something.
So it is individual, whether you want 2 meals a day, 3 meals a day, and all that sort of stuff. If you've got target weight, we do it to a target weight as well. Even if you say I'm going to do 3 days of a sardine fast, I've actually can add that to a meal plan. So you've got the whole thing, you've got a shopping list. It's a really good service, actually. It's all done for you. That's about 30 quid a month, and you get 4 weeks straight off. You get week 1, week 2, week 3, week 4, with all different recipes. So meal plans. I do exercise programs as well. If you want to do a little bit of that, I can do that. That's all online. You get the workout sheet, which is, like I say, online, and there's illustrations of every exercise, and then there's a built-in timer, which, as someone that used to train, I think this is brilliant, because I'd have like my workout book, and then I'd have an interval timer. This, you just press start, and let's say you're doing bicep curls. Let's do a bad bicep curl. You're doing your bicep curls badly like this.
Yeah.
There'll be an illustration of how to do a bicep curl. It's a cartoon thing, but it's well drawn, and it will have your time or your reps.
Okay.
So if it's 30 seconds, you just press start. And it isn't just the exercise, it's the whole routine. It's got rest things in it. It's a fabulous bit of software. It's third party. I didn't design it. It's great. That's Workout Labs. Very good. And there's constant feedback on that as well, so you can tell me at the end of the workout. So I haven't got a lot, but we do. If none of that appeals to you, Richard Smith and Richard's been on this program, we run a low-carb school community, which has got loads of free courses, loads of ebooks and everything that you can take away and download, and that's $4 a month. It's less than $1 a week. So, and that has a live question and answer once a week, and you can come in and ask your questions, and Richard can answer that and take up the whole hour. Or I can answer it and take about 10 minutes. And there's like 400 like-minded people on there.
Yeah.
And you can share recipes, and if you've got problems, you can put it out there and see if anyone else has that problem. And finally, we do completely free live question and answer every Sunday at 7 p.m. on YouTube, whole hour.
And the channel is called?
Well, it depends. If you go to Richard's, it's Keto Pro, and mine is Coach Stephen or Stephen Thomas, Bachelor of Science. You can type in the UK Carnivore and you'll see that. So loads of stuff.
Cool. Stephen Thomas. Coach Stephen Thomas.
Yes.
It's been fantastic. Thank you so much for coming on down. We could have talked for so many more hours, and I'd love to have you back once you've got a bit more data about some of the things that you said. Thank you so much for coming.
Well, thank you for having me. It's been an absolute pleasure.